Good morning, everyone, and welcome. Thank you for joining us for the 2021 Virtual TNT Conference. My name is Rita Michaels, and I'm the Director of Operations at the Georgia Transplant Foundation. I will be joined in a little bit by Rebecca Moshiri, who's our Director of Patient Services, and we will be your moderators for today's conference. This webinar is made possible thanks to our presenting sponsor, CareDx, and in part thanks to our virtual sponsors, Community Walgreens and Synergen RX. Today's TNT, we'll start with a quick GTF 101, and then we will have speakers share their unique and transplant stories and the journey that led them to become faces of hope and encouragement for so many. We will then divide into organ-specific breakout sessions to hear important information and updates from transplant doctors. But before we get started, we have a few housekeeping items to cover. First, today's webinar is being recorded, and we will share the link with you by email once the event is over. You will be muted, and we cannot see you in the webinar portion of this conference. You will not appear in the recording. Next, we'd love to hear from you during today's presentation. If you have any questions for a speaker, please type them into the Q&A chat box at the bottom of your screen, and we'll be answering as many as possible. I want to remind everyone that the information you hear today from our Face of Hope speakers is based on personal experience, that they are not physicians, and that each person must be sure to defer to their own doctor and transplant team regarding their own transplant and medical health. And now, without further ado, let me turn it over to Rebecca.
Good morning, everybody. As Rita mentioned, my name is Rebecca Moshiri, and I'm the Director of Patient Services at the Foundation. We're so glad to have you here with us today. First, we would like to kick off with something that we typically do at the Atlanta TNT, and which many of us look forward to each year, and that is to find out where in the transplant process you are, and then we'll have a question, if applicable, for how long everyone has had their transplant. Right now, can you choose which group you're in? Are you a transplant candidate, recipient, caregiver, a professional who's attending, or other? So we'll give a couple more minutes to have everybody participate. We're having a lot of answers come through. All right, so it looks like about 60% of the people who are here are transplant recipients. We do have a couple of caregivers. We have a few transplant candidates, some professionals, and then some in the other category too. Now what we'd like to find out is, of the transplant recipients, how long have you had your transplant? It's so exciting to see this.
Look how many people are over 15 years already. It's amazing.
That is really amazing. So right now it looks like the majority of people have had their transplant 4 to 7 years, which also is just amazing. And then we have a couple who've had it 6 months or less.
Wow.
And a few who've had theirs over 15 years too.
6 people.
Yeah, it's really exciting. It's so amazing to see. And we just thank you guys so much for being here and participating in today. So now I'm going to do a quick overview of GTF and the programs and services that we offer. If you would like more information after this presentation, please visit our website. And then also just a reminder, after this webinar, you will receive an email from us, probably on Monday, that has more information about GTF's mentioned offerings. So GTF was founded in 1992 by Tommy Smith, who was a transplant recipient. We now offer many programs and services. We have financial assistance, the transplant fundraising program, and education and community programs. First, I'll tell you a little bit about our financial assistance programs. Patients who are working to get listed or who are already UNOS listed at a transplant center and or Georgia residents are eligible to apply for assistance if there's a need of a situation of need that's related to transplant. First, I'll start with our pre-transplant programs. So we have our dental assistance program, which may be able to help you if your transplant center or your insurance is requiring you to get dental clearance prior to being listed. We also offer assistance with insurance premiums for non-Medicare UNOS listed patients who are currently missing work due to their disease progression. Our evaluation assistance program may be able to help with travel and lodging costs if you're getting evaluated at a transplant center that's far from home. And then we also have a program to assist living donors with travel costs and lost wages. And now I will tell you about programs for our post-transplant patients. Our emergency assistance programs help with household bills if there's an income loss that's related to transplant. We offer short-term medication assistance to make sure that you can always take your meds while you work with your social worker to plan how to cover the costs moving forward. We can help with lodging if you live far from your transplant center and you're required to stay locally either right after the transplant or when you go for follow-up visits. We also offer assistance with health insurance premiums during a time of job loss or job transition. And then we offer transportation assistance to help with the cost of fuel for traveling back and forth to the center for follow-up just after transplant surgery when you have a lot of follow-up visits. So the important thing to remember about all of these programs I've just told you about is that you will need to apply through your transplant or dialysis social worker. And they're all short-term grants to sort of help you get through a hump in the road. Next slide, please. Next, I want to tell you about our transplant fundraising program. So for this program, it is really there to help patients to prepare financially for the costs of transplant. And you can do that through fundraising and a matched grant up to $10,000. So in order to apply for the matched fund program, you do need to apply when you're pre-transplant, and then you have 1 year to complete your fundraising that we will match. And then the funds can be used post-transplant to help with your transplant medications and insurance premiums. To get more info, you can go to our website or talk to your social worker, either dialysis social worker or at the transplant center. And many times the financial coordinators also can help you get information and get a copy of the application. And you can also find it on our webpage. Next slide, please. We also offer many education and community programs. We have the Jumpstart program, which is a return or transition to work program that can help with education and with help with resumes and job training. And that's available for recipients, caregivers, and living donors. We have the Mentor Project, where we're able to train transplant recipients to offer hope and encouragement to people who are going through the process. And then we also offer TNT conferences. In the past, pre-COVID, we would have the conferences in person, and we hope to get to that again. But for now, we're offering them online, virtually, and still want to be able to offer education and a time for transplant recipients to be able to meet. Then we have tutoring assistance that is offered for pediatric patients who have missed a lot of school due to their transplant and sickness that happens along with the process. We offer academic scholarships. These scholarships, the application will open in January, and then people must submit their applications by May 1st, and it's to help students who are seeking post-high school education or training. And then we also offer a couples enrichment weekend. We know that transplant does affect that couples relationship, and once you're post-transplant, stable, and at least 6 months after the transplant, then you would be eligible to attend. It's a weekend that's held at St. Simon's, and it's just a time for the couple to really focus on their relationship again. Next slide, please. So for more information on any of these programs, please go to our website, gatransplant.org. Now, at this time, we have another poll question. Where do you live? We would just love to know where the people who are attending today are from throughout the state. So far, it doesn't look like anybody is answering.
I think we're having a technical difficulties with the poll, so we're going to end it right now.
Okay.
Sorry about that.
That's okay. And if we need to skip it, then that's all right too.
Yeah, let me. Is that working?
Oh, yeah. Looks like that's working. All right, so far as answers are coming in, a huge majority are from Atlanta, but we've also got some representation from Savannah and Rome and Athens and Columbus. Oh, now I've had a couple pop up from Albany and Valdosta area. All right, so it looks like almost 75% of the attendees are from the Atlanta area. But like I said, we have some people from all over as well. So thank you for being here. You know, the one nice thing about having to hold these conferences virtually is that you can attend from anywhere. But we do look forward to getting back and seeing each other in person again eventually. So now I would like to hand the floor over to Dr. Stephen Potter, who's going to start today's presentations. Dr. Potter performed his surgical residency at the Johns Hopkins Hospital and his transplant fellowship at the University of Cincinnati. He's a transplant surgeon in the Division of Abdominal Transplantation at Baylor Scott & White in Temple, Texas, and a clinical associate professor of surgery at Texas A&M School of Medicine. Dr. Potter, thanks for being here, and please take it away.
Rebecca, thank you so much. I'm going to share my screen here so you can see my slides. And you should be able to see my first slide now.
We are seeing the first slide. We do also see a little version of the next slide over on the side too.
Yeah, I need to switch that.
If you hit end slideshow. And then at the bottom, right next to where you can zoom. Bottom right.
Mm-hmm.
Keep going to the right. Next to where the where it says 84% next to that, right over one more.
There should be a way to just switch the screens, Rita, so that the full shows up on the bottom.
Yeah, if you, from before, if you hit end slideshow and then at the bottom where it has the percentages, there's a little button you can press and it will put it into the regular view.
Not seeing that.
Hit end slideshow, end show.
I did.
Oh, because we're still seeing it. Not sure. I mean, I guess just go this way. I don't know. It seems like it's frozen.
Yeah.
So all the way down at the bottom.
Mm-hmm.
Okay, so you see where it says comments, and then there's 4 little boxes to the right of that. Hit the last box. All the way down at the bottom right.
Down here.
I don't see your mouse, but next to comments and to the right of that, there's one that's highlighted or it's gray. And then there's 3 more. Hit the last one.
Yeah, there's nothing that says comments over here.
All the way down at the bottom of your the PowerPoint window, it says notes, then it says display settings, and it says comments. We can just do it like, there you go. Yes, now go over to the right. Keep going to the right and keep going, keep going. One more. There, hit that. There you go. You're ready to go.
Yeah, but are you seeing the one slide or the multiple slides?
Just one.
Okay, outstanding. All right, guys. Well, that was an inauspicious way to start a talk. So thanks for your patience. We, believe it or not, we ran through that last night and it worked fine. So I apologize for the delay. It is a fantastic honor to be here today, and I'm so happy to talk to you guys about transplantation. We're going to cover some stuff that sounds sort of complicated, molecular biomarkers and transplant, what's new. But really, this is all about folks waiting for transplant and folks who've been transplanted. And I'm here essentially just really humbled by the opportunity to talk to you guys who are always the people with the hardest jobs in transplantation. And I'm open to any questions, and I hope we have a good discussion at the end. I'm going to try to keep it relatively brief in terms of the science and go through some key issues. So here's are some disclosures. I'm here just talking to you as a transplant surgeon, but not representing Baylor Scott and White Health or any of these other roles that I serve. So we have kind of an aggressive agenda today, a lot of stuff to cover, but again, we're gonna breeze through a lot of these slides. It's all about sort of the take-home messages I hope to leave you in terms of how to get your transplant journey to be successful. So we'll talk a little bit about the transplant kidney ecosystem. The talk's going to be sort of kidney centric because I was asked to give a talk about kidney, but I see now from the polls that there are folks with different organs from all over Georgia. And so if you are a liver recipient, I apologize that a lot of this is about kidney, but you'll find that there are a lot of relevant lessons here. A lot of what we're talking about is absolutely applicable across all organ systems. So why is kidney transplant surveillance so important? We'll talk about what Alisher is, which is a test for helping do surveillance for your organ transplant. Some take-home messages from the key studies that were used to validate Alisher. Those are the DART studies and the RADAR studies. And we'll talk about how Alisher results can get to you and your doctors and how the logistics work there, and tell a little story about a kidney transplant recipient and how they did. And not so much in terms of the pre-transplant side, but in terms of how they did after transplant and how surveillance for their transplant and compliance with their medicines is important. So let's just look at the math for kidney transplants for a second, because it's really, if you're waiting for a kidney, if you're looking to get listed, or if you've gotten your transplant, these are important numbers. And I promise we won't do any calculus, but we're going to look at some numbers here. So in the United States in 2019, there were 23,401 kidney transplants done. And of course, the numbers for the other organs are much, much smaller. And that sounds really, impressive until you realize that there were 98,057 people waiting for kidneys. So, and that is as of last week when I put the talk together. So there's a huge mismatch between supply of kidneys and the need for kidneys. We just don't have enough living donors, and we don't have enough deceased donors. Now, there is some good news. We're doing a better job every year of transplanting folks. Numbers are going up every year. In 2018 to 2019, we had, again, a 10.6% increase in the number of transplants done. And even during COVID, which was horrific for all concerned and really disrupted the entire healthcare system, the transplant community managed to increase the number of deceased donor kidney transplants done, which I think is really a testament to the dedication of everybody involved and how robust the system is. So what's one of the key problems? I mean, we're transplanting more people every year. We've seen that we have way too many people on the waiting list, and we want to get those people off the waiting list and get everyone transplanted. Personally, I went into transplant because I hate seeing people on dialysis. Dialysis is at least a way to stay alive. And for many of you facing the need for other organ transplants, there is no equivalent machine. So this is a stark issue, really, really critical. And one of the key issues is that we aren't doing a perfect job of keeping people's kidneys and other organs working after their transplant. And if you look at kidney, where the data is most robust, 17% of kidneys fail within the first 5 years after transplant. So late transplant loss is a huge issue for all of us. 17% of kidneys fail within 5 years. About half of them have failed within 10 years. And the main reasons that people lose their kidneys late are graft injury due to immunologic issues, primarily rejection. A lot of those rejection episodes that occur later are associated with non-adherence with medication. And that's easy to happen because people do well and they sort of move taking their medicine and following up with their doctor down their triage list of all the important things that happen during the day. So it's easy to kind of let that drop off. The folks that are attending this meeting are atypical, right? I noticed from the polls, you tend to skew later in terms of your course after transplant, and of course are really super engaged, bright, and very knowledgeable. But finding that folks don't take their medicine is an ongoing issue for those of us caring for transplant patients. And it's really the number one thing that everyone who gets a kidney or another organ can do to ensure success on their journey long term. Why is it so important for this system? It's important for this system because people that return to dialysis after losing a kidney typically are going to be candidates for another kidney. And so when they re-enter that pool, they join that big list we talked about of 98,000 people who need an organ, and they end up getting an organ that would have gone to someone who had never had a transplant. So if we can get kidneys to last longer, patients will do better, more kidneys will be available for new patients, and the system will be able to take better care of everyone. So that has huge ramifications long term. So that's something we want to work on. There is cause for celebration, though. If you look at the rate of graft loss long-term, we have seen improvement. And if you look at these lines, these are cohorts of patients, recipients undergoing kidney transplantation with kidneys from deceased donors. And if you look at that kind of brown line on the top, that's people that are 10 years out. And the cohort is based on the year they were transplanted and how they did for the next 10 years. So the folks who got their kidneys in about 2003 are at the top far left, and the 10-year folks going forward to about 2008. You see that graft survival is improving by that curve going down slowly but surely, and that's true for all the time points. So you see people at 5 years, 3 years, 1 year, and at 6 months. You see that we're doing a really pretty good job, especially in the first few months, of taking care of people and helping them keep their kidneys. The issue is we really aren't. We need to do better. We're not doing as well as we can do, and we need to serve our patients a little bit better than that. So a lot of data on this slide, which I just put this slide up here to make the point that a lot of graft losses are due to missed medication doses or stopping medication long-term. And there are lots of reasons that can happen. Financial reasons, which you'll learn about today in the seminar, some of the ways that you can make sure you don't lose coverage, some of the ways that the Georgia Transplant Foundation and other organizations can help you with short-term coverage so you don't run out of medicine. But I want to make the point that meticulous adherence to your medical regimen is critical for your outcome. Transplant's a team effort. There's sort of a partnership between you and your transplant team. But what I tell patients every day is it's not really a partnership in the sense that you guys have the hard job and the rest of us have the easy job. Yours is by far the hardest job, and then your family members that have to go through your illness with you and your recovery, they have the second hardest job. And we're just privileged to be able to care for you. But the number one thing that you can do to ensure your success is take your medicine without fail. And if it seems like I'm perseverating on that point, it's because those of us in transplant see this every day where people, fall off the bandwagon on their medicine. So that would be something to avoid. So the risk of kidney allograft loss is really too high, despite our best efforts. Transplant recipients deserve better, and there's some innovative ways we can improve. So if you're a kidney recipient and you're being followed after your transplant, you know that early detection of problems with your kidney's function is really critical. And you know that monitoring the health of your renal allograft is an important way to detect that early dysfunction. The problem is, for us as clinicians, there have been about the same tools for 2-3 decades that we've been using. One is we check your creatinine, which is that blood test. When we look at the number, we want the number to be lower rather than higher. That creatinine test is readily available. It's relatively cheap, but it's insensitive, and elevations of your creatinine can be caused by lots of different conditions. And then you know about biopsy, which is where you put a needle in the organ and get a piece of tissue. That's expensive and it carries some risk. So that's not ideal in many ways. So if you kind of make a square where you have things that are not invasive, which we like, right? We like to have things offered to patients that don't involve poking holes in them. And we like to have things that are accurate. But if you make a square and look at the available options, you see that in the upper left, you have creatinine and donor-specific antibody. Those are non-invasive, but they're also not very accurate. And in the lower right, you have biopsy, which is more accurate, and you get a tissue diagnosis from the kidney, but it's invasive. And what we'd like is something that is both non-invasive and more accurate, and that's where donor-derived cell-free DNA testing comes in, and that's what Alisher is. So it's a way to check how your kidney's doing without having to get a biopsy, and it can give you some important information. So what is it actually? Well, you have a donor organ in your body, and it's full of DNA from the donor, right? And when you have injury to the cells in the donor organ, you get release of more of that DNA into your blood. And so now you have that donor DNA circulating in your blood, and we can actually do just a regular phlebotomy blood test and measure how much of the DNA circulating free in your bloodstream is from the donor organ and how much is from you. And then that produces your Alisher level, and a high Alisher level indicates that you may have rejection. So here's a schematic showing if you get a donor organ, it's pretty cool because it's from a different person, and suddenly you have two complete sets of DNA. And DNA from all our cells is being released into our bloodstream all the time, just sort of normal turnover. And it happens very dynamically, like with a rapid turnover. And so it's very dynamic, it's always changing. And so it gives you a tool to monitor that allograft health. And I'm not going to go into a bunch of details. I just want to show you that Alisher really was the first validated donor-derived cell-free DNA test available in the United States. And it was validated in a multi-institutional study, lots of hospitals. The demographics of the enrolled patients were very consistent with the demographics of the country as a whole, which I think is very important. It was a diverse group, very inclusive. And the goals of this study were to compare this molecular marker, Alisher, with the performance of serum creatinine, which is what you all normally get when you go to the office. When you go to get your blood draw, you always get your creatinine checked to see how your kidney's working. How is Alisher discriminating the presence of rejection from the absence of rejection, which again is the number one reason that people are likely to lose their kidneys after a transplant. And we want to determine the ability of Alisher to discriminate antibody-mediated rejection from the absence of that type of rejection. And that type of rejection is less common, but a very common cause of late renal allograft loss. So when folks are 5 years out from their transplant and they get that type of rejection, that's a common reason that they lose their grafts, and we want to be able to diagnose that. So here I'm going to just point out the threshold, because if it comes up in conversation with your physician team, this is a relevant number to remember. You want to have an Alisher level that's less than 1%. If you have an Alisher level over 1%, it's a very important marker of the possible presence of you're having rejection in your transplant kidney. The other thing that Alisher can do that's very important for patients with kidneys and with other organs increasingly is it has a high negative predictive value that can help rule out rejection. So if you have an Alisher level that's low, which most Alisher levels are going to be low, that's kind of like a rest easy at night, sleep easy kind of number, because it gives you assurance that you don't have rejection. And if your Alisher level is less than 0.21, that gives you a 95% likelihood that you don't have rejection, which is really neat because it's that rejection that kind of smolders and sneaks up on people that can really cause havoc. Finally, if you have a high Alisher level, and by high I mean over 2.9%, you're very likely to have underlying antibody-mediated rejection, and that can help your clinicians focus on the problem right away and make sure that you get the biopsy that you need at that point and the treatment that you need. So let's talk a little bit about, for the folks that have already received their transplants and have kidneys, it'd be really satisfying to know that you would have a marker like Alisher that's low when you are not immunologically having a problem, when your kidney's doing fine and you're not having rejection. And you see then the left, they're sort of in this kind of schematic, no active rejection, you have a low Alisher level. And then you see that it bumps up when you have the onset of rejection and peaks during active rejection. What you'd like to see is that if you get treatment for your rejection, you return back to baseline. And that's indicating that your kidneys kind of return to a healthy state and is no longer under immunologic attack by your body. And so that's kind of neat. We'd like to see that. And in fact, we do see that. We've actually looked at that. And we looked at patients who had kidneys, got rejection, and looked at their Alisher levels before, during, and following treatment. And what we found is that with treatment for rejection, Alisher levels fall back towards their baseline. So Alisher may actually be useful in detecting and assessing your recovery from an episode of acute rejection, which is really fascinating, I think. So this slide makes one relevant point, I think, and that is that Alisher is like a lot of other tests or just vital signs or weight or whatever you get when you go to your doctor's office. It's best used as a longitudinal test. So it's best to have numbers over time to help your physician team kind of make sense of your Alisher levels rather than just getting one level. establishing a baseline level and then seeing how changes happen over time gives you a lot of valuable information. Now, in folks who have rejection, Alisher actually can be very useful too. So this is a very interesting study where 79 kidney transplant recipients at 11 transplant centers who had known rejection. And these are types of rejection that are relatively mild. And in the transplant world, these are two types of rejection. We call them TCMR1A and borderline rejection that we're not really sure what to do with sometimes. These are mild rejections that may or may not be associated with damage to the kidney in the short term. And we don't want to overtreat people with kidney transplants for no reason. So we looked at whether Alisher levels could help figure out what's going on. And if you have an Alisher level that's high versus low, we found that can be very important in predicting what happens to your allograft. So in this study, patients were grouped by their Alisher levels and then were followed to see what happened to their kidney when they had this known mild rejection. And what we found is that if you had a low Alisher level when you had your initial biopsy, you had no one who lost kidney function over the course of the study. But if you had an Alisher level that was over 0.5, you had a significant loss of kidney function during the study, which is that red bar on the right. Those people had a negative change in their kidney function. They lost horsepower in their kidney over the course of the study. And if you look at the table, it's even more dramatic. So people who entered the study with a low Alisher level and had these biopsy findings, only one of them developed new antibody against their kidney during follow-up, and none of them developed rejection. Whereas in the people who had an Alisher level over 0.5%, 40% of them developed new DSA or donor-specific antibody, and almost a little over a fifth of them developed new rejection during the study. So that's kind of a neat way that a molecular marker that you just check on a blood test can help predict the significance of known rejection in your kidney. Now, this is what's called a violin plot, and it just shows you some of the key thresholds for Alisher, so when you have a dialogue with your physician team, some of these numbers are kind of going to stick in your head. So if you have a low level down there in the green, that's sort of your peace of mind score. You can rest easy knowing that that number is good. If you have a number over 1%, then that should be a threshold for active rejection. That should trigger more getting done. And if you're over 2.9%, that gives you a very high predictive likelihood that there's antibody-mediated rejection going on. So these are just for the folks that are not transplanted yet. These are some of the things that this is part of what you and your team together will work on after your transplant to try to ensure that your journey down the transplant spectrum is as uneventful as possible. And because rejection is so important, this is one of the ways to sort of to help monitor you and avoid unnecessary biopsies and ensure good outcomes. So this is kind of why this is relevant. So how do you get tested for Alisher? You can do it at a hospital phlebotomy lab during your visit there. You can do it at any third-party lab, or they also have mobile phlebotomy that can drive to your house and draw your blood free of charge. And that's kind of a neat feature, especially during COVID, because it keeps you away from folks as we move into the next, sort of wave of pandemic. That's potentially value added, I think, for patients. Your doctor will get a report that shows your Alisher levels over time and flag various thresholds. So you and your physician get Alisher results pretty quickly. 90% of Alisher sample results are provided to your physician within 3 days. For other similar tests in the marketplace, the number is much lower. Only about 31% of other tests in the marketplace are available in 3 days. Alisher is also fully covered by Medicare and a number of payers. So Medicare beneficiaries with Part B are covered at 100%. It's also covered by Medicare Advantage plans and Medicare secondary plans and a number of commercial payers. And CareDx provides patient support services and includes prior auth help, appeals, and a lot of financial assistance. So is this study experimental, or is this kind of widely adopted? I would say it's moving rapidly into being standard of care in terms of your care as a kidney recipient. 80% of transplant centers by volume of kidneys transplanted nationwide use Alisher. Over 60 transplant centers have a protocol that just protocolizes the use of Alisher for everybody, and over 35,000 kidney transplant patients have had Alisher testing to date. Alisher has a lot of support for transplant recipients. CareDx patient managers are actually physically waiting for your phone call to help you on your journey. It gives you a single point of contact for your entire Alisher experience. You get courtesy notifications regarding upcoming blood draws and scheduling of at-home blood draws for your convenience, which I think is a really neat feature. Some areas of the country, like interestingly in New York City, they make very wide use of that remote blood draw service. Other areas that are more rural make less use of it, where you think it'd be most practical. But it's a fascinating and really promising endeavor. So let's talk about a kidney recipient story, and you're going to hear much more compelling stories from two transplant recipients today. I'm going to just briefly review some of the issues from like the transplant surgeons at the table on how does this post-transplant journey go from our standpoint. I went into transplant though because of stories like this. There's nothing really more exciting and amazing than seeing someone get off dialysis and walk out of the hospital. And I've had patients that had no high school degree, got transplanted, got a GED, went on to nursing school, and two of them actually became transplant coordinators after getting their kidney transplant. So watching people go through those journeys over the years is really unbelievable. And you guys that are listening in this meeting here and participating in this meeting are the ones that make it all possible. And those of us that are lucky enough to be doing the surgery are just humbled by being associated with you. This patient was 64 years old, African-American female who had diabetes, and that's what led to her kidney failure. And she had a lot of other conditions that are very, very common in our patients around the United States. So people don't typically just have kidney failure, they typically have other things, and she had diabetes, high blood pressure, peripheral vascular disease, and heart disease. She received a deceased donor kidney from a 61-year-old donor. She got routine immunosuppression. I won't go into the details there, but was on the standard regimen that most folks in the country are on. In terms of her journey after transplant, everything went great up until 15 months. She had some baseline Alisher levels, which is his donor-derived cell-free DNA molecular test we talked about. At month 3, 6, and 12, she had normal Alisher levels. You see that they were all really low. And her creatinine was perfect. So it continued stable. It was 0.9 to 1.1 the whole way through. And at month 15, her creatinine was still 1, which is a normal number. Like that would be the same that you'd see in some healthy patients with 2 kidneys. So really doing outstanding. Everything's on track. But her Alisher level went up to 0.85. And that's a significant change, but still not over that 1% threshold we talked about. So we elected to follow her more closely, but we didn't order a biopsy. And many of you with kidneys have been in this situation, and those of you who are going to get kidneys will be in this situation where your team is looking at these numbers, trying to decide how aggressively to intervene. Is there, how concerned are we about underlying rejection and so forth? So she comes back a month later, her creatinine was still normal at 1, but her Alisher level was now 0.91%, and she had no evidence of new antibody against the kidney. And so given that Alisher level had gone up a little bit, we got a kidney biopsy. So we had our radiology colleagues stick a needle in the transplant kidney and get a little piece of that tissue and look at it under the microscope. And what we saw was a mild form of acute rejection called TCMR1A. And that was treated with high-dose steroids, IV steroids administered during a brief hospital stay. And at month 18, her creatinine was still 1.0, which is great. And her Alisher level had returned back down to baseline, which is kind of like recapitulates the data we talked about earlier, where not only does Alisher predict rejection, But when you treat it, the Alisher level goes down. So that's kind of nice. So what lessons can we learn from this patient's post-transplant journey? Creatinine measurements failed to detect early allograft injury, or creatinine rise, in other words, was delayed, right? There was rejection going on, but you couldn't tell from the creatinine. The Alisher baseline levels that were available provided reassurance of allograft health and also helped trigger an early kind of red flag that something was going on. The Alisher elevations prompted the biopsy. Changes in the Alisher level over time can help guide those clinical decision-making, by your team. The use of Alisher in this case may have led to earlier diagnosis of rejection. And with therapy for rejection, this patient's Alisher and creatinine levels returned to baseline. So let's kind of summarize what we've talked about with these molecular markers, and in particular, this very exciting thing called cell-free DNA. Alisher is a marker of acute injury. It's a negative result for Alisher is strongly supportive that your kidney does not have rejection. Alisher is more accurate than creatinine, which has been kind of the marker that we've relied on for decades to diagnose allograft health. So Alisher, in that sense, is a more accurate predictor of underlying rejection. Alisher is very sensitive in picking up antibody-mediated rejection, which is a cause of late allograft loss. Alisher levels decrease following successful rejection therapy, and the utility of Alisher is optimized by getting a baseline level and then following levels along. More importantly, we talked about sort of the critical importance of adherence to your medication regimen and communication with your team to try to optimize how things go along the transplant journey. And I would be honored to answer any questions you may have, not just about what we talked about in the talk, but anything about the pre-transplant space, the post-transplant space, organ allocation, anything that is of importance to you that I can maybe weigh in on. Thank you so much for your time.
Thanks so much for your presentation, Dr. Potter. That was some really great information, and we have had a few questions come in. One question is, will Alisher replace serum creatinine and/or biopsy for me, or will it be used along with Alisher?
That's a great question. And if you're facing a biopsy, you know, it's a little scary. And if you're thinking you may have rejection, it's a little scary. The answer is that Alisher in our practice has been very helpful in avoiding unnecessary biopsies, but it's not going to replace biopsy because we still need to know what type of rejection you have, and we still need to be able to get that tissue diagnosis, if you will. So Alisher is going to be used in conjunction with creatinine and with biopsy as needed, but it may help avoid some unnecessary biopsies for folks, and particularly in the heart transplant world. Donor-derived cell-free DNA testing has been really, really useful for avoiding excessive numbers of heart biopsies that those of you who live in that world as heart recipients know that becomes the bane of your existence very quickly. It's a lot of biopsies, and they can produce damage over time. So donor-derived cell-free DNA testing is critical in that potential for preventing unnecessary biopsies.
Okay, thank you. Somebody asked, do most physicians offer this? Is it just something that I should bring up to them as an option?
Yeah, I mean, I think transplant's unique in that it's really a team endeavor. And like I said before, you guys are the most important part of the team, and you have the hardest job by far. And everything revolves around you. But that doesn't mean that everybody's gonna, that folks are gonna sort of repeatedly ask you about, do you want to get this novel test that's becoming standard of care? So I think it's very helpful to ask about it and just say, well, is this something that we can explore? I think that the vast majority of transplant surgeons and the vast majority of transplant nephrologists are familiar with this test, and if they certainly have the ability to order it for you, no matter where you are in the country. When you get an Alisher test, all those tests are run at a central facility. And so there's really good quality control. Everything's done in one place. So your test goes to the same lab. And so I think the turnaround time is pretty remarkable, and the validity of the data is pretty remarkable. And I think it'd be worth asking about.
Okay. Is Alisher used for all organ transplants, like heart and liver as well?
So no, not all organs. That's a very good question. So the reason I focused on kidney is there's so much volume in kidney and so much accumulated experience and data. Alisher is used widely in heart. It's approved now for lung as well, but it is it's not approved. There's not a formal pathway for its use in liver yet, or in pancreas, but more to come on that. So at this time next year, I think we may have a very different conversation, because we do have data in liver recipients that's very promising, and we have data in pancreas recipients that's very promising. And what we found is, as you might suspect, that the level of Alisher and the significance of that level is different for the different organs. So as we go through this process of gathering data, we're starting to really produce robust data that will help guide therapy in liver recipients and in pancreas recipients. At this point in time, if you are a recipient of a liver or a pancreas, or you have a KP, a kidney pancreas, then you can, I would suggest that you follow up with the CareDx folks that are on the call today. I think Rusty's on the call, and he can help guide you through that process of how you would request that, because you can still get the test and it still be covered, but it's something that Rusty can help guide you through how to do that endeavor.
Somebody asked, are there any drawbacks to using Alisher?
Well, there's certain populations of people that should not get Alisher levels, or where you can't tell the validity of Alisher, and there are special populations. So, for example, anyone who's pregnant, you should not be getting a donor-derived cell-free DNA test, because there'll be some confusion with the results there. If you've received a kidney from an identical twin, then you don't have two full sets of DNA like the rest of us would have if we had an organ from anyone other than an identical twin. And if you've had a bone marrow transplant, then you all, for similar reasons, your cell-free DNA is going to be different and not able to be interpreted reliably. So those would be special populations of people who you'd want to avoid getting an Alisher level. Also, your doctors aren't going to want to order Alisher levels right away after your transplant. They're going to want to wait at least a month before they get an Alisher level, because a number earlier than that could be confusing and hard to make sense of.
Okay, and that is something that somebody had asked, like how soon after transplant are people tests done to measure for any rejection or through Alisher, and then how often is that testing for any potential rejection done?
Yeah, I mean, we test typically quarterly for the first, we test every month for the first 3 months or so, and then quarterly after that. But you know, if a lot of people also do less frequent testing long term, and that's perfectly reasonable as well. And that's something that really you and your transplant team and your community nephrology team that follows you long term will have sort of some idea of what they like to do and how they should set that up.
Okay, and speaking of that continued follow up with your team, what, you know, as somebody who has been in transplant for years, what would you say is the most important thing that a patient can do in order to succeed in their transplant journey?
Well, so post-transplant, I think I kept hammering away at that, you know, and this is a group that is self-selected for people that are really smart and take their medicine all the time and communicate effectively. I mean, it's sort of a different group, right? But taking your medicine is really important. And the way to look at it is, you guys remember, has anyone ever watched The Wizard of Oz, where the guy was behind the curtain, right? There was this little guy behind the curtain, and everyone thought he was a big scary magician. And once the curtain was pulled back, then the game was up. And that's kind of how immunosuppression works for your kidney. The whole idea is that when we modify your immune system by giving you these medicines, what we're attempting to do is pull a curtain over your organ and prevent your immune system from seeing it. It's kind of like that simple. And when you miss medicine doses, the curtain gets pulled back. And the problems may not occur immediately, but once that curtain's pulled back from missing medicine doses or having levels that are too low, your body can develop antibodies against your organ that you've received from your donor. And once that happens, then there's a chain of events immunologically. There's a whole bunch of little actors in your body floating around that are doing things that lead to a pronounced likelihood of rejection and a pronounced decrease in how long you keep your kidney. So if you kind of think about it in that term, you want to make sure that kidney is protected from your immune system at all times. And the best way to do that is take your medicine all the time. I would say on the pre-transplant side, there are lots of things people can do. And it's really about being engaged. And I think pushing your care team a little bit. I mean, professionally and politely, but you want to be engaged in your care and don't be shy. Ask questions. If you go to a transplant doctor and you ask them questions and they don't seem to want to answer your questions or they don't answer them satisfactorily, I'd say go to a different doctor. You guys are the most important part of the whole process, and we're all here for you. So if you find that people are uncomfortable or insecure with your questions or your attempts to be engaged in your care, then something's not right with that equation, right? Because we're all here for you. If there are modifiable risk factors you can work on pre-transplant, please do so. And that means, like, if you smoke, it's good to stop smoking. If you weigh too much, it's good to lose weight. But the number one thing I would say is walk more, exercise as much as you can, because the stronger you are and the better your balance is when you go into the hospital for your transplant, the easier it is going to be to rehab and the more potential you're going to get out of things. That sounds really simple, but sometimes the simple things are true.
That's very true. Well, that's all the time that we have for questions for Dr. Potter, but we are so appreciative of this presentation and of the time that you've given today. Thank you. Thanks for being here.
Rebecca, thank you so much for allowing me to be here. It's been really an honor for me. Have a great day.
Thank you. You too. And next, we will have a moving story about somebody's transplant journey. I would like to introduce you all to Candice Stevens. Candice is from Macon, Georgia, and is a kidney and pancreas transplant recipient. She's a graduate of Westside High School and Valdosta State University with a BBA in accounting. Her husband, Jabron Stevens, was her kidney donor, and she has a daughter named Kobe that's 15 years old. She's been employed as an auditor for the past 15 years. She's also a realtor and personal finance coach. She is a GTF mentor, and her hobbies include volunteering, reading, shopping, and traveling. And without further ado, I would love to turn it over to Candice. Good morning, Candice, and thanks for being here.
Good morning. Thank you, Rebecca. That was a very good bio introduction. Thank you.
You're welcome.
So before I get started, usually when I share my story, I do very well. It just depends. So if I break down at any point, you guys just break down with me and support me in the journey of telling the story. So with that said, I will go ahead and get started. So my journey began when I was 7 years old. I was diagnosed with type 1 diabetes. And if any of you are diabetic or know anyone that is diabetic, you know that diabetes is just a monster, especially at 7 years old. I remember my mother sharing the story with how she kind of felt like, there wasn't something right with me because I was just constantly thirsty all the time. I had this frequent thirst, this frequent urination, and she said I just had a weird look about me, and especially in my eyes. So she took me to my pediatrician at the time. And when they checked my blood sugar, it was like 425. And my pediatrician was immediately, oh, I know exactly what this is. So the tests were ran and that's what it was. And that's when I guess the rest of my life started, in a sense, because everything just changed like that, you know? So it's like when I'm, you know, growing up and going to school, you know, with the other kids, that I consider myself abnormal because I have to go to the nurse's office and get the shots and make sure that I'm eating the diabetic diet, the healthy diet. And it was just really hard as a child growing up with diabetes and trying to maneuver things. I remember being hospitalized a lot in the beginning, until I was able to get on a regimen that worked for me. And I remember going to, you know, camps, diabetic camps that my endocrinologist, he had a very wonderful, exciting camp. I don't know if any of you ever know him in the Middle Georgia area. His name is Dr. Jones. He has the Jones Center in Macon, Georgia. So I was a part of that program for a long time. And I learned a lot going through middle school, high school, still kind of tweaking things here and there, but for the most part, I did well. But it wasn't until I got to college that kind of changed the course of everything for me. So I remember the very first semester that I went, I struggled a lot because my parents were like drill sergeants when it came to what I was supposed to eat and what I wasn't supposed to, because I'm at home, so I'm covered. And my parents are cooking everything and making sure I'm not having too much salt, too much sugar, too much this, too much that, because I'm in Middle Georgia. My family is from a very small country town where sugar is king, salt is king, Crisco is king. All the bad things are king in this area. So it's hard to not indulge in those things, especially coming from the family that I'm from. So it was kind of hard to navigate. And so when I went to college, I was exposed to that. I was sheltered when I was at home, but when I went to college, I was exposed to all these different things, and I just felt captive to them because I'm like, oh, I feel so free and so excited to do things that I really didn't get a chance to do before. And I don't have my mom and my dad, you know, on my shoulders, like, no, you can't do this, you can't do that. So I felt liberated and I just wanted to feel normal. And in doing so, I know that Dr. Potter was saying, you know, taking and adhering to your medications is key. It is. And I did just the opposite of that. I just went through a really rebellious stage where I was like, I don't want to be diabetic. In my mind, like I had a choice, right? But I just felt like that. I just went through this really rebellious, I don't care, I'm not taking my meds, and I wasn't watching my diet, I wasn't exercising, I wasn't doing any of the things that I was doing prior to being on my own, you know. So I did that. I was in and out of the hospital the entire college existence. I can vividly remember we were actually doing a project on patient care. It was a project on how long it takes for patients to go through triage in order to get to their room. And I'm like, oh, this is the perfect project because I know all about that. And it came down to the day of the presentation, and a week before I was hospitalized due to my own fault, you know, just not doing those things that I should have been. So it just kind of caught up with me. And I remember my professor saying, this is exactly why you were a part of this project, because you had the knowledge, you had the skill, you had everything, but you still didn't do what you needed to do. And I said, you're right. So they sent me a link to the presentation. So I had to watch it from my hospital bed. And it sucked because I had poured so much into it. And I felt like at that moment, I'm like, okay, that could have been a turnaround moment for me. I had a lot of those could have been turnaround moments, but I felt like, okay, this is the one. But what did I do? I did not turn around. I got out of the hospital. I was back to my normal thing. Just total rebellion. And I think I just was angry at that point. Like, even though I've gone through all of these things, I still, like, I'm young, I still have time, I can figure it out. And, life is still happening the way that I'm choosing. Not the choice I should have made, but that's what it was. So I'm continuing, I've graduated, I've come back home to Macon, I'm starting my career. And again, I'm still like, subconsciously like, I'm young, I still have time, I still have time. So I got a little bit better about getting back on my regimen, seeing my doctors and all of that. And it got to 2015, I'll say maybe November, December 2015. And I went to see my nephrologist at the time, but he was relocating to another state. And he said, I'm putting you in the best care because at this point, I'm relocating and I'm leaving, and I don't know that the things that I've shared with you that you are, listening to what I'm telling you, because you're on a path to kidney failure. And I'm just like, wait, what is that? What do you mean kidney failure? And I'm like, subconsciously, okay, I hear what he's saying, but I'm young, I still have time, not worried. So I'm like, okay, good luck to you in your career. And I think it was Missouri. So I started seeing this nephrologist, and on the very first visit, he's like, we need to talk. Your kidney function is at 30%. And I'm like, what? Repeat, start over. Is that my file? I think you have somebody else's lab, because that can't be me. So I'm like going through all of this, and I'm saying these things to him, and he's like, I'm not joking, that I will show you. And we went through it, and I couldn't believe it. And I'm like thinking, how in the world could this happen? Like, I know how it happened, but I'm like, how did this happen? So I felt like that was another could have been turning point, but it wasn't. It just didn't click with me about how serious my health was at this point. It didn't dawn on me yet still, even at 30%. So at this point, now my body's kind of starting to shut down, internally, like my body, I'm feeling bad all the time. I'm in pain all the time. I had to have stents put on the left and right side of my kidney. I was in the bed all the time. I would go to work, go home, get in bed, that's it, because I just didn't feel like doing anything. I didn't have the energy, and I was retaining fluid, so I was bloated all the time and feeling so full and so tight. So now things are starting to manifest as they had told me they would, and I'm still subconsciously like, I'm young, I got time. So I'm going through 2016, and now we're checking my labs like literally once, maybe twice a month, I think, at that point, because now I'm reaching that dialysis threshold. And I'm like, okay, something has to give. So they're like, you need to get on this low sodium diet. Okay, cool. Tried it. And I was like, this sucks. I can't do it. Nothing about it is good. And I love good stuff. So I still like, I have time. And we're now at June 2016. And my doctor's like, Candice, you're now at like 20. So we have to start making some decisions. And he's like, dialysis or transplant. And I'm like, I choose option C, neither one of those. I don't want any of that. Like, what are your other options? He's like, there is none. So we need to be finding you, a way to get on the list. You need to be asking, people to help. And I'm a very private person. I had not shared with anyone what I was going through at all. Only people that knew was my husband and my parents and his parents. So it wasn't like everyone around me, they knew I was diabetic, but they didn't know the severity of my situation. So I started asking family. Everybody was so excited to want to donate, but for various reasons they could not. So my husband just said one day, Candice, I don't think we need to ask anybody else, because I feel like I know it's me. I know I'm going to be the donor. And I'm just like, are you insane? You are like the worst eater in the world. All the bad stuff, he loves it. So if you give me this kidney, you might kill me. You can keep it. I don't want it. So I'm like trying to talk him out of not wanting to do it. And he's like, no, I'm serious. Like I know he hates needles. He hates doctors. So I'm like, there's no way you're going to do this and have to go through all this rigorous testing and all that. He's like, you're going to see, just trust me. So we went to Piedmont. Behind the scenes, my nephrologist was sending my information out to various transplant centers, and we went to Piedmont and they ran all the testing that day, and the doctor came back and he was like, "You're not gonna believe this. This guy is a perfect match." And I'm like, "What?" I could not believe it. Like, he was so calm about it. And he's like, "I told you, like, I just knew it." And it was amazing. It was such an amazing feeling to know that, one, to have married your ultimate match, and for him to know that, it was surreal. It's still surreal. Even when I talk about it now, it's still very surreal. So we had our surgery. We scheduled our surgery for December the 2nd of 2016 because we didn't want to miss Thanksgiving and Christmas. So we went through Thanksgiving, and so we were in recovery in December of 16. And the recovery was great. I think I was pretty much fully recovered after 3 weeks and feeling amazing. So Jabron had a very rare condition after his surgery, and it was the inflammation of something called I think it's the omentum. Dr. Potter can correct me if I'm wrong on that, but I think it's the omentum, like the inner lining of the stomach. It was very inflamed and he was in a lot of pain, but it's a very, very rare condition that happens. I want to say the doctors or the surgeons told us maybe less than 5 or 10%, something like that. So he had to go back in for them to take care of that part of the infection that was going on. And so after that, we were smooth sailing. I didn't have any complications with my surgery. Everything went well. So I have the kidney, and we're pumping and we're going great. And my surgeon's like, "Well, what about the pancreas?" And I'm like, "Well, what about it?" And he's like, "That's how, we're curing diabetes. That's the only cure for it at this point." And I'm like, "Okay, I'm feeling like a champ. I've survived kidney transplantation. So yeah, put me on the list. Let's do it." And I'm thinking, okay, they're never going to call me anytime soon, because if you've been on the waiting list, it can be a long time. And maybe I was listed in July of 2018. And on October 4th, I was awakened by a phone call that said, "Hey, we're ready for you. You need to be headed to Atlanta." And that was the second most exciting call that I've ever had in my entire life. After being diabetic for 28 years, I knew that day it would be over. And I was so excited. Like, the first surgery, I was nervous. I cried all the way until anesthesia knocked me out. I was just crying because I was scared. But that call, I was excited. I wanted to be awake for it all, but I knew that wasn't possible. But 3 hours later, on October 4th, I was free from it. And that is the most amazing feeling ever. And that surgery, I had a couple of complications with that surgery, in which I prepared like a little PowerPoint to kind of show y'all the transition of the journey that we were on through the recovery and everything. So I think I was hospitalized 20 something days of the first month of the surgery, because the pancreas, they tell me, is a very sensitive organ. So there were some complications, but after that, even after all of that, it's like the best pain I've ever experienced. I'll tell anybody, I would do it all over again if I had to. Hopefully I won't have to, but I would. So that's kind of my transplant story, in summary, because it's so much meat and potatoes to share inside of it. But that's just a summary of how I started and where I've kind of ended, but not really, in a sense. So I want to pull up this PowerPoint that I have prepared. So give me a second here to share it with you guys. Hopefully you're all able to see this.
We can see it.
Okay.
Yeah, that's perfect.
Okay, great. So I'll go through some of these pictures together. Okay, so this is the evaluation day where Jabron is having his day before evaluation with the doctors at Piedmont. This is the day before surgery. The picture on the left is we're at the Piedmont, well, I'm at the Piedmont Lodging Center. Jabron is out dining without me because I don't think I was able to eat after 12. So I was kind of sad. On the right is where I'm the night before, where I have all these emotions going on. Excited but nervous at the same time. This is the day after surgery, where Jabron comes down to check on me and we pose for a photo out the day after. This is him 2 days after. I snuck in on him that time. This is when we were back in the hospital, and this was a little bit closer to Christmas, and some of the pictures while we were there. We made it to Christmas with our family. I think he got out a week before Christmas. This is our first day back to work in January, and I'm feeling like, okay, I'm pretty fly today. So let me take a picture of my first day back. And this is the pancreas transplant. And I told Jabron to make sure he captured when I woke up and I was diabetes free. So this is what this is. This is 4 days after the transplant. We spent our 7-year anniversary in the hospital, but this anniversary is going to always be special because it was the year of the pancreas transplant. This is the first visit back to the hospital after the pancreas transplant. And I'm back again for the second trip. I had an infection that they had to get rid of. And this is like, I'm out of here, throwing up the deuces, the peace sign. I have officially beat diabetes at this point. I'm not coming back to see y'all, not as a patient. So 5 months later, I had a pajama party with some of my friends and my cousins, and it was pretty exciting because I turned 36, and it was 5 months after. So I came up with this 36 and 5 theme, like a 365, just kind of saying every day is a special blessing. Every day after, all I've been through is special to me. So that's kind of where the 365 came from. And these are some pictures where we were on vacation the following year. And this is just a snapshot of where we were then, where we are now. So on the left, this is our wedding day in 2011. And we just renewed our 10-year vow renewal on October 16th of this year. So I just wanted to show the comparison of then and now and where we've been the past 10 years in this crazy journey together. And so to end it, I just put my contact information. As Rebecca stated, I'm also one of the mentors for the Georgia Transplant Foundation, and I'm also the support group facilitator. And here's my email address if anyone wants to take that down. And we meet every third Thursday from 7 to 8 o'clock for those that are interested in joining the meeting. Just give me an email, shoot me an email. And that's it.
Candice, thank you so much for sharing your story.
You're welcome.
So,
Thank you for having me.
First, I do want to remind everybody, if you have questions, please feel free to submit them through the Q&A box. Candice, what, it sounds like you had such a long journey with diabetes, pre-transplant, and then obviously even after the kidney transplant until you got the pancreas. Was there a certain sort of mantra or phrase or Bible verse or anything like that was sort of the thing that you would turn to that would, kind of got you through all of that time?
Yeah, my mother is a very religious person. We prayed together a lot. And I didn't want to feel defeated because I've always been a competitive person, never wanting to lose at anything. So I felt like this was no different. So even after all of the rebellion, I still subconsciously kept telling myself, you're still young, you still have time to get this together. And I think even in the midst of all of that rebellion, I still felt like I'm going to win. So that coupled with my mother, that's what really got me through it. Honest to God.
So it sounds like your mom's support was
Yes.
huge for you.
Yes.
You did mention that when you were going through the kidney failure, that you really weren't sharing it much outside of your family. Did you at some point share with everybody, you know, once you got transplanted, or how did that sort of work out with sharing with your friends and community support?
So, like I said, I didn't share. I just have never been. I mean, who wants to talk about that? Who wants to go, hey girl, let me tell you about this kidney failure? No one wants to have that conversation. So I began sharing only when I got to the 15% kidney function mark, and my doctors really like, Candice, you have to do something. So that was the something I had to share, because I actually had a fistula put into my left arm, and the very next day it clotted. And he's like, well, we need to go back. And I'm like, yeah, no, we're not doing that. That was the moment. And I said, you know, I don't feel dialysis. It's not my route. This happened for a reason, you know? So it's like, now I'm in share mode. Now I have to call and text and say, hey, I need to talk to you. Would you be willing? Would you be willing? And so after the surgery, my husband posted it on Facebook, and he knows I hate my business being on Facebook, but he did it anyway. And it got so much support and love and shares and likes and love. So I was like, okay, it wasn't that bad thing, you know, in the overall scheme of things, because I didn't know how many people were on this journey with me, because I wasn't sharing it. I wasn't talking about it. So that's how it kind of morphed into what it is now.
Right, that totally makes sense. And it seems like now, you know, one of the things that you really enjoy doing is you facilitate the support group. So it sounds like through the journey, you've really learned how much that support means. Right.
And in hindsight, I wish I had a support group at the time that I was going through things, but I was just dealing with it the way I always do, in my own way. So, and I know I know the Piedmont had a support group at the time, but I didn't know about it until after the surgery. And so I also volunteer with them as well, and they have support groups that I join as well. So I'm always willing to share my story and the information and the resources that I have, because there's so many people that are suffering with, you know, kidney failure or lungs and, you know, all these other organs. And so anything that I can do to facilitate, you know, positivity, encouragement, that's what I do.
Yeah. And yeah, just like you mentioned just now, the support group, the virtual one that Candice facilitates, that's, you know, offered by GTF, it is for all organ groups. It's for pre-transplant, post-transplant, anywhere in the journey. You know, you're welcome to attend. We would love to have you there. How is your husband doing since he was your living donor?
Yeah, he's doing well. We operate a catering company, and we have a huge wedding today. So I wanted to get him to pop in for a second, but he couldn't get away. So, but he's doing well, even after the second surgery or the second situation that he had. Ever since, you know, he's been doing fine.
I'm so glad to hear that. And it's just so special that he was the perfect match for you. Yeah, I guess in more ways than one.
Right. Who would have known?
Exactly. Well, Candice, thank you so much for sharing your story. I hope that you're able to look at the chat box. So many people have responded to your story and think that it's inspiring, and thank you for sharing it. We truly appreciate you sharing it today. Thank you for being here.
Thank you all. Thank you all for listening. I appreciate it.
Well, next, I would like to introduce you guys to our next Faces of Hope speaker, Chris Webb. Chris is a 44-year-old from Tampa, Florida, and he currently resides in the Atlanta area. He's a computer engineer and manager in the financial technology industry. He has a passion for cars, racing, technology, fitness, and animals. He's married and has a 10-year-old daughter who is his life. He practices a healthy lifestyle and is proud to be over 3 years sober. Today marks 1 year and 9 months since his liver transplant. He passionately promotes liver health, organ donation, and transplant whenever and wherever he can. Chris, thanks for being here. I'm going to pass it over to you.
Hey, thank you, Rebecca. First and foremost, thank you for having me. And those on the call, if you would, just bear with me. This is my first conference that I'm joining. I've joined a lot of the support groups that were offered pre-transplant through my hospital. In fact, I attended every one while I was going through the process and waiting for listing and waiting for transplant. But this is my first open conference where I'm sharing my story. So I've made some notes that I'm going to go through. But again, just thank you for having me, allowing me to share my story. It truly is a passion of mine, and it's not only to raise awareness for organ donation, the transplant process, but also for liver health and the process of everything involved if you do become ill. Again, I'm 44 years old, as mentioned. I have a 10-year-old daughter. I'm married. But before I get started, I want to share, I just want to say, because I think we have some people on here that are pre-transplant. So I just want to say, we're all different. So I'm going to tell my story. I'm going to tell the good. I'm going to tell the bad. But just remember, just like in our illness and our symptoms, our recovery is all different as well. So, don't base your own story or, what you have in front of you based off of my, some of my shortcomings or some of my successes, right? I think I've had a lot of both. So, I just want to get that out there right away. So a little bit about my background. So, growing up, I was a very athletic person. I played all sports. I got started in my career very early. I was just around 20 years old. And, I progressed every year, got better at what I did. Feel my career took me to high levels very early on. So I experienced a lot of success early. Just like most, I had a pretty social life where I would socially drink. I'm going to talk about, the alcohol aspect of this because it was a part of my life, right? But I ended up becoming to a point where I was drinking every night. I was drinking wine, a few glasses of wine before bed, during almost every night for about 10 years. Fast forward, going to my doctors, I started developing some high blood pressure. So it was a requirement for me to get medication to go every 6 months to get that medication refilled. And sooner than later, I started, started talking to me about my liver enzymes were creeping up. So naturally, like Candice was saying, I put it off for a while, thinking I'm young, I can handle this. Nothing's going to happen to me, right? And so I would back up, I would clean up my diet, change my lifestyle. I was always very active in working out, lifting weights, playing basketball. So it was easy for me to kind of bounce back, by changing my lifestyle up a little bit. So a couple of times I did that. I would stop drinking and, I would kind of return to normal. But then I would start drinking again. And I did that a couple times up until the very end, which was about 3 years ago, a little over 3 years ago. My bilirubin started to climb, and that was something that had never happened before. And it was the final wake up call for me. So, I completely changed my lifestyle. I put alcohol away for good. And when I was about 9 months sober, my aunt passed away, and we went down to Tampa for that funeral. While in Tampa, and by this time I was doing very well. And before I went on this trip, I actually had some ultrasounds done with my GI doctor, a new GI doctor that I got that I really liked, that walked me through, everything, explained everything that was going on. And I showed significant improvement. I got the ultrasound and it was an all clear, right? I had fatty liver, but everything was improving. So I continued to stay clean and sober. Attended a lot of AA meetings, did everything I could for myself to try to improve, and it was showing. It was doing really good. But when we went down to Tampa for that funeral, we ended up staying for about 4 nights. My daughter was young; she didn't understand funerals, so we kind of made it a little bit of a vacation, right? So we stayed downtown, and every day we were walking around doing the parks. Enjoying the swimming pool at the hotel, just being a normal, active family. The final day before the funeral, we took a river taxi around Tampa, and we stopped at a restaurant. At that restaurant, we ate, and I had 6 raw oysters for an appetizer, and ate a grouper salad. Everything was fine. Went back to the hotel, and that final morning, we went out to a park, went to the swimming pool, and then started getting ready for the funeral. Went to the funeral, and at the funeral, it was like a light switch was turned off, right? It was just like someone flipped a switch on me, and I was immediately deathly ill with no warning. It started with I was very shaky, very cold. I kept having to leave and go outside to warm up and come back in. And I was explaining, I tried to tell my family that something was wrong with me. Everyone dismissed it, or was dismissing it as, I was stress, or it was, anxiety from being at the funeral. But I knew it wasn't that. So I ended up leaving and going back to my hotel. And then my wife stopped and got a thermometer because people said I felt hot. I threw up 3 times on the way to the hotel, and there was some blood in that throw up. I had no idea what was going on, right? We literally went from being healthy, walking around, being active, to being very, very, very sick. I took my temperature, and I had a 104-degree temperature and this was while throwing up. So I knew I had to go to the emergency room. We went to Tampa General Hospital. I threw up 3 more times on the way, got in, and I was thinking I was having by this time I had a little bit of pain in my stomach. So I thought I was having a gallbladder attack. I was the only one left in my family with that still had a gallbladder. So I told them that when I went in. They took my vitals, and as soon as they took the vitals, they took them ahead of everyone else. They took my vitals, and she got on the phone and she called someone, and they came out with another machine, and they took my vitals again. And my blood pressure was 50/30 with 104 degrees confirmed temperature. So I ended up going straight back they took me to trauma, where it was like a scene from a movie. I had felt like 20 doctors and nurses on me, trying to figure out what was going on with me. Had stents put in my neck down to my heart to bring my blood pressure up. And it took a while. It took a while for them to get me to what they considered a stable state, right? But my liver numbers weren't showing bad whenever they went in and checked that, because they were going off of just like the enzymes. So my enzymes weren't that high, but as they got me to a stable state, I went into the ICU, where they started taking care of me, and they found that I had a very, very aggressive bacteria in my bloodline, in my blood, and it was Vibrio, or what we commonly know as the flesh-eating bacteria. The doctors came to me. They told me that they found this, and they literally told me that everything else is off if we don't figure out what this bacteria is, because they didn't know it was Vibrio at the time. If we don't figure out what this is, you're going to die. So it was very, very hard. They brought in the CDC. They started backtracking everything I've done over the weekend. They kept asking me if I've been to the beach, if I had a cut, if I've been in the water, if I've been wet. They couldn't figure that out. They kept harping on that, but I never was at the beach. I never got wet. So then we started backtracking everywhere I went. And when I mentioned the oysters, it was like a light went off in their head. Everyone left the room, and they compared my blood samples with Vibrio, which is flesh-eating bacteria that was going around in Florida. This was back in 2019. So they figured it out and started treating me. I spent about a week and a half in the ICU, and they got me. I started recovering. I lost my kidneys for 3 days during all of that ordeal. Miraculously, they came back the night before I was scheduled to go on dialysis. And then that's never been a problem since. After a week and a half, I was improved enough to come back to Atlanta. But they put a midline in my arm, and I had to give myself IVs for a month straight. All this time, I continued right back to work. So needless to say, I made a complete turnaround in my lifestyle. When I left the hospital, I asked the doctors what was the number one thing that I could do to improve my situation. And they told me lose weight, because they told me they suspected that I had cirrhosis. So I came back, started seeing my doctor here again, the GI doctor that ran my tests 6 months prior to this, that were all good. And sure enough, I was full-blown cirrhosis. At the hospital, I had a MELD of 32. And then I spent the next year chasing a listing, being listed. I was recommended to go to Piedmont Hospital, which I did. Became part of a great team. But I spent that entire year almost with a MELD of 28 to 30. In that high of a range. So through all of my changes I made in myself, I spent a lot of time studying liver disease, studying the liver, figuring out what it does, and how to improve my situation further. I lost 60 pounds. I think it was both through my diet, but it was a little easier to do because I was in full-blown liver with liver disease, stage 4 cirrhosis. But I was able to get myself very healthy, down to a healthy weight. And through all of my tests, the doctors actually said I was extremely healthy, everything except for my liver. So by the time that I was able to go through the health evaluations, the health screenings, the 2 days at the hospital where they run through everything. I was in such good health that when I went for my heart, for my stress test for my heart, whenever I stripped down and started getting all this stuff put on my chest, the nurses looked at me and they couldn't believe the shape I was in. So they asked me if I could run on the treadmill. I actually ran on the treadmill for 13 minutes straight. Took my heart rate up from 55 to 180 almost during that time on the treadmill. So that's just a testament to as good a shape as I got myself in. And I attribute all of that to my studies and kind of understanding, how the liver works and just figuring out how I could keep myself alive during this time, because during this entire year, it was really, really bad. I think we have some people that are on that have been through liver transplant and some that are maybe seeking transplant. It's a very, very difficult time. All of our symptoms are different, but there are many, many days where I could feel myself slipping away, and that was an extremely scary situation for me, for my family, for everyone around. Although I got myself into a very good condition where I looked physically fit, physically healthy, I suffered from severe jaundice. My bilirubin was around 12.5 for a long time, and I was able to get it down to 8, I believe it was, when I got transplanted. But I stayed up in the upper 20s. I got transplanted at MELD 28. It was March 3rd. I got a call. I think my call came in around 10:30. I was sleeping. I answered the call. I looked at my phone. It was Atlanta, but it was an unavailable number, and my heart kind of just dropped. I knew what that call was going to be, and I answered, and it was Piedmont Hospital asking if I could be there by midnight. Of course I did. I drove myself to the hospital. My wife met me in the morning after we got got a babysitter for our daughter. And the next day I went into transplant. I was happy. I was ready for it. I knew I was physically ready. I knew I did everything in my power to be the best that I could be for that transplant. And I think, as I'm looking back, I think that was scary for my family, just seeing me not in a worried state. it's hard to explain. Just everything I had been through. I knew I was ready for this. I knew I was going to pull through. I never felt like I was not going to make it. So I went in with that attitude. My surgery took over 8 hours. I think I woke up 14 hours later, is from what I remember. And from there, it was very good. Everything I did prior to transplant to get myself ready actually paid off. The doctor earlier was talking about this. The best thing that you can do pre-transplant is, staying healthy, doing everything you can to get yourself to the best you possible going into the transplant. And it really did work. It worked for me. I woke up and I was walking at hour 13 in the ICU. I was actually walking around hour 10. So 10 hours later, I bugged my nurses. I told them I could get up. I had used the bathroom already. I told them I could get up and walk. They kept telling me, you can't. You think you can, but you can't. And finally, I got them to let me try. And I got up and we took a walk around the whole unit at hour 10. And at hour 13, I was transferred to my own room in the transplant unit out of ICU, which was really unheard of. And people were amazed. I was amazed with myself, and I'm really proud of, my journey, everything I put in and how I've recovered. I was out of the hospital and back home in 5 days. Another very good feat, right? And I was back at work in 30 days after transplant. So fully functioning, driving, everything. But my journey hasn't come without speed bumps, right? I've been through quite a lot. And so this is the piece that I'm going to go into that I don't mean to scare anybody with, but it's part of my story and I want to share it. So I've had 2 small rejection episodes coming out of transplant, both of which I had no idea what's happening. So this is a testament, and I want to salute our doctors and everyone on our teams, because all of the blood tests you do in the beginning, I was going twice a week for blood work, and then they kind of taper that off. But, the return visits, the checkups, the blood work is all being done for a reason. They were able to catch these small rejections very early and treat it with high levels of steroids, right, through the medication. And I recovered really quickly from both of them. The first one was just medicine adjustments. The second one, I actually had to do some prednisone IVs, high doses, and I continued on prednisone for a year to make sure that I had no more rejections. So those were all, very easy experiences besides the prednisone. Those of us that are on prednisone, we know the side effects. We know what it does to us, hard to sleep, some of that stuff. But the biggest thing was I also had to take insulin for a long time because of my blood sugar and what it did to my blood sugar. All of that, though, is now gone. I live a pretty normal life. But 7 months after after these 2 rejections and feeling completely normal and healthy and very active, we went back down to Tampa. And I also forgot to mention that I came out of my transplant right into the pandemic. It was when they shut everything down. So that was a really scary process, as you can imagine, coming out of transplant into a pandemic, not knowing what's going on, how this is going to affect you. But 7 months later, things started to calm down. We went down to Tampa again, and we went to a beach. We felt very safe during the pandemic. There was no one out. We followed all the guidelines. But during that stay, on the last night on the beach in Tampa, I started feeling some pretty bad stomach pains where I couldn't sleep. And it was very hard to get comfortable. It started getting worse and worse to the point where I had to, I was in such pain that I was actually on the floor, like fetal position, not knowing what was happening. And I thought to myself, I thought I was losing my liver, right? I thought I was in severe rejection. I had no idea how it could go this quickly, but I ended up back in Tampa General Hospital, the same hospital from where I was diagnosed after eating the oysters on the last day of my vacation. Same as before. I went to the transplant unit because, I was, freshly transplanted, ended up in the same room with the same nurse from previously after I was let out of the ICU, and because back then they put me in the liver unit. I ended up with the same nurse, same room. And it was found that I had a diaphragmatic hernia that was caused by a pinhole in my diaphragm, most likely from the transplant procedure. This is extremely, extremely rare. And, I had no hard feelings on it. My life has been saved. It's just something that happens to a very small amount of people, but it was very, very serious. My stomach had pushed through this pinhole. My actual stomach organ had pushed through the pinhole, and it was sitting on my lung and heart. So I was in major, major pain. They saw it in a CAT scan and immediately took me to emergency surgery. It was another life-saving surgery. I wouldn't have lasted much longer. So after that, I stayed in Tampa for another week, came back, and from there, everything's been smooth sailing, with the exception of needing a bile duct. And that was 3 months ago. I needed a bile duct. They noticed that my GGT, several of my numbers, that your GGT and your 2 enzymes start to rise. When they see this, they know that it's from bile duct. So I had a stent put in to open up the bile duct. That is caused by the narrowing of that bile duct where they sew it in, right? So I had that put in, and it was removed 30 days later, and everything since has been very, very successful for me. And I don't even consider everything I went through as being not a success. It was just part of my journey. It was some hurdles that I had to get through. And today I feel as if nothing happened, right? Sometimes I forget that I'm transplanted, besides having to take my medicines. I'm down to only 2 medications. I take 2 milligrams of Prozac, Prograf, I'm sorry, not Prozac, Prograf per a day, and 1 pill of Cellcept that will probably go away here very soon. And the rest are just my supplements, I take my vitamins and stuff. So besides taking my medicine, I am extremely healthy. I'm very active. I'm, in some of the best shape I've been in my life. I am not jaundiced, which is one of the biggest things. So if there's anyone that's on the call that is, suffering from jaundice, yeah, I feel you. I think we all do. We know how demoralizing that is. I spent a year very, very bad shape like that. And depending on how well I was able to hide my jaundice, some people didn't know I was sick all the way up until my transplant. But at the very end, it became very hard to hide. I did go to work with my jaundice, went out, did my routines, and it was very demoralizing for me. To me, it was one of the worst symptoms. After I got myself into shape, I was able to control all of my other symptoms through my diet, which was very good. The ascites, everything I was able to control very well through all of that. And besides the jaundice, it was hard to notice. So the jaundice for me was hard for me. I think it's hard for everyone else, but I have some pictures to show at the end here of, kind of my journey. Sadly, I don't have any pictures of myself when I was at my worst. That was, right after diagnosis. And frankly, I didn't know if I was going to live. So I wouldn't allow pictures to be taken of me, because in my mind, I didn't want to be remembered in that state. Looking back, I wish I would have taken those pictures now, right? So I encourage people that are in the pre-transplant stage to document your journey. I've documented everything through my journey, with the exception of those pictures when I was at my worst. And I do wish I had them today to be able to share in my journey. But other than that, I'm just looking at my notes and see if there's anything else that I wanted to go through here. I'd love to take whatever questions I can at the end, but pretty much that's my journey. Today, I'm 1 year, 9 months transplanted. I'm almost 3.5 years completely sober. I never considered myself to be an alcoholic before, because I didn't understand what an alcoholic was, right? I led a normal life what I thought, right? I drank at night, to calm down, whatever. I had a ton of excuses for why I did it. But I was never the stereotypical alcoholic that, I think of as an alcoholic. Today, I know that I was, so I'm extremely proud of my sobriety. I'm very proud of my journey. I'm proud of where I am now. And I'm not afraid to talk about it. And I think that's one of the most important things through all of this is knowing your self-worth. Number one is coming to terms with your diagnosis. For me, in the very beginning, that's hard. And, through all the support groups and Facebook groups that I'm on, and I try to lend my support, that's one of the number one things that I see through everyone's journey is, it's very hard to come to terms with your diagnosis, what led you to it, some of your own faults, getting that out of the way as quickly as possible, and owning up to that stuff is very important. And it was very important for me. Once I was able to do that, I was able to focus on living, and life got better very quickly, even while I was ill. So that's kind of my journey.
Thank you so much, Chris. Did you have photos you wanted to share?
And I'm going to share my screen right now. I had to change the computer, so I'll have to go through each of them individually. But let me get to a share real quick.
All right.
All right. So I want to start with a before and after. This is a before picture of me. This is me when I was drinking on the left. This is about a year before diagnosis. I had let myself go pretty bad, right? I was, obviously this is a bad picture, right? When we do before and afters, we want to try to find the worst and the best, right? So that's what we're seeing here. Let me see if I can blow it up, if it's, make it more viewable. So this is it. This is me at my worst. And this is me, the picture on the right was about, I believe 9 months after transplant. But my journey immediately after transplant was very rewarding. I already did not look like the picture on the left, but my jaundice started clearing up. The minute I woke up, I remember waking up and asking the nurse, my nurses were so nice, beautiful. They were like my angels. And I remember one of the first things I would ask for was a mirror. I wanted to look at myself. And although I came out of transplant and somehow I woke up with a black eye out of transplant, I joke with the surgeons that they beat me up during the surgery, but I woke up and I almost cried. Like I could see my eyes were like 5 shades clearer already, just after waking up from transplant. My skin took a little bit longer, but I started improving very quickly. So let me get back out of here and back into the next pictures. The next picture, this is after I started losing weight. This is on my journey after the oysters, after I was, after my diagnosis. This is about 4 months after. At this point, I had already lost, I think, 40 pounds, and I lost another 20 after this to get in even better shape. But this picture is important to me because this is one of the first pictures I took of myself after I started feeling a little bit more comfortable with myself, that I was going to make it. My skin tone in this picture is not tanned. I had not been in the sun here in, at least 4 months. I stayed inside. This was during my hardest times when I didn't know if I was going to make it. I hated the way I looked. I was much more yellow than this. So, I didn't go anywhere. There's zero tan on my body here. I was fortunate through this that at times my jaundice appeared to be a tan to some. Some people didn't know, but as you got closer, I was in your proximity and speaking with you, my eyes didn't tell it. They were honest, right? My eyes were terrible yellow. So I wore sunglasses a lot. I squinted my eyes. I did everything I could do to hide it because I didn't want to feel like I was different, right? I didn't want to be treated different. And, you know, and like Candice, I didn't share my story with everyone. You know, I hid it from a lot of people and I was ashamed, right? It was something I wasn't proud of at the time. So it was very hard, but this is a picture that kind of shows how I was. And if you can imagine this twice as bad, that's how I came out of, you know, out of the hospital the first time, and I was much heavier. So this is kind of a progress pic. The next picture I have is, this picture is, this is a picture less than 1 week before I got the call for transplant on the left here. I was going to my daughter's, a daddy-daughter dance for my daughter. She was 8 at the time, or 7, almost 8. In my mind, I thought this was probably going to be the last daddy-daughter dance I was ever going to do. I was so unsure of my life at the time, and where I was going, right? I had just gotten listed. When I got listed at the time, it was when all the standards had changed as far as MELD scores and how livers were being divvied out across the country, right? They went to a zone instead of from the state. I don't know if anyone's aware of this, but where liver and organs were once coming from your area and your MELD scores were based on the state where you lived, Georgia had a high percentage rate of being transplanted in the 20s. When all this changed, it looked like it was going to be much different. And the reason they made these changes was because, you know, the need for organs in places like California and New York were far greater, and people were dying at like a MELD 38, MELD 40 while waiting on transplants, while in Georgia, people that were less were receiving them. So, you know, there was good and there was bad through all of this, but it made it very uncertain for me at the time. And I didn't feel very comfortable because although I knew I was in somewhat good shape, like this picture on the left doesn't lie. You could tell I was sick there. Every day I felt like I was dying. You know, I'd have random nosebleeds anywhere. You know, it didn't matter. If I cut myself, I'd bleed for 45 minutes, like some very serious complications. Although I was up and walking around, I knew what my complications were. I knew what they meant, and I was very uncomfortable. So I thought this was going to be my last daddy-daughter dance. The picture on the top right is at the hospital after I got the call. I remembered to take a couple pictures of myself to see, to track the journey, and this was waiting to be called into the OR. So I took a picture. You kind of see where my eyes and my skin were at that point. The picture on the bottom, obviously, is right after the transplant. This is what my scar looked like. This is right after I had the drains taken out. But this picture is a piece I wanted to stop on. One of the pieces that I was unaware of, I was so prepared for everything, I felt like, but one thing that I wasn't ready for was the buildup of fluid and the ascites that you would get after transplant, right? I went into transplant and I had, you could see a 6-pack on me. Like I could see my abs. And I woke up and I had 40 pounds of fluid on me. And I wasn't prepared for this. And that was the hardest part of my recovery. Even when I went home, I still had this fluid around me and it was so uncomfortable. I think many of us have felt this, so you know what I'm talking about. But this was the only piece I wasn't aware of and wasn't ready for. So I just wanted to share that with those that are maybe going through transplant. Don't be scared of it, right? I'm sharing it because I tried to be as prepared as possible as I could for everything. And I think if you know going in that this is going to be something that you may or may not deal with, it's better to be prepared for it, right? And it did get better, right? After I went home, I think it was after 2 weeks, and I was getting my staples removed, it was still there. And they started giving me some diuretics, and they started with Lasix, and it worked only for like 1 round, but it didn't do anything. Then they gave me Boomex, and this is absolutely insane, but they gave me the Boomex, and I I peed 35 pounds in less than 2 days. So when that happened, it was a great relief. And from there on out, it was smooth sailing until I hit some of those little hurdles in my journey. So Sharon,
Yes, thank you so much. That's amazing to hear about. We've had a couple of questions come in, and we're close to the end of our time. So I want to make sure to ask a couple of these. So somebody said, it sounds like you, weren't really taking good care of yourself, and didn't feel like you were in good health before you did get the diagnosis, and then you found out. And you were talking about how, it took a little time to just get used to the idea of the diagnosis. But then it sounds like you really sort of took control of your health. Like how did you get to that place, to being able to just take control as much as you could of the thing you could control?
That's a good question. I hear it a lot. So the picture I showed you, obviously, like I said, that was my worst. That was at my worst time, the very first before picture. Between that time and the time that I actually got diagnosed, I had already stopped drinking, and I had lost some weight as well. So I was already on my path to a better, healthier lifestyle. But with that said, I talked about in the beginning, I have a very athletic background, and I spent a lot of time working out. So there is a lot of good in my story before I got to my worst state. So I was able to use my experiences from the past to help myself lose weight and kind of fall back into some of the old habits that I had through my studies about liver health and how to take care of yourself and live a healthy liver diet, have a healthy liver diet. I quickly found that what we know as a liver healthy diet is also a bodybuilding diet, almost to a T in a lot of cases, right? So I was able to revert back to some of my old healthier ways before I kind of let myself go and kind of adjust that in certain ways, right? So first thing I did is coming out of the hospital the first time, and with my diagnosis, I couldn't eat. Like, I was extremely sick. I had no appetite. It was very difficult to eat. So I went on a vegetarian diet. I started with fruits, mainly like melon type of fruit, watermelon, all of that kind of stuff. Something that was easy to eat, that was able to give me some of the cleansing benefits that fruits and vegetables do. And then I went to a greens diet. And as I started to get my appetite back, I just ate an extremely clean diet, lots of vegetables, lots of grains, only fish, well-cooked fish and chicken and turkey, stuff like that. So lean proteins. I use protein supplements, only certain supplements that were low in sugar, no fat, low in cholesterol, to help me get to the shape that I was in. At the very end, I will say though, as I got even more sick, I was consuming about 4,500 healthy calories a day to stay at 190. 190 was my goal weight that I tracked and stayed at, 190 to 200, because you can get a liver from someone 50% of your body weight, less or greater. So that was my goal, to stay there, and I was able to stay there. But at the very end, it was very hard.
Wow. Well, I guess that really does tell you how, everybody's body is different, and yeah, it can require, so many calories to stay healthy. Well, Chris, we can't thank you enough for sharing your story. I hope that you're able to look at the chat and see you've gotten so many messages about your story, and it's really been inspiring. And we appreciate your time and you sharing it so much. I'm so glad that you are healthy and thriving now.
If you don't mind, could I just show the last couple pictures? I'll be quiet.
If you can just do it extremely quickly. Sorry, we need to work on getting to our breakout sessions.
I gotcha. Okay, I'll make it really quick. There's just one that I'm really proud of that I want to show. So
okay, please show it.
I was able to get this license plate, and I was very surprised about it. So I'm in, like I said, I'm in the cars, I'm in the car show. So I got this license plate, and this is something I'm able to talk about all the time. So I was just very
Oh,
available, and I was able to get it. And this is what I drive around with every day. So on that note,
that's amazing.
thank you. Thank you.
Well, thank you so much, Chris.
Thank you. I'll just give it back.
All right. Well, I want to thank our speakers this morning, Dr. Potter, Candice, and Chris. You have just shared wonderful presentations, and truly, your stories have been inspiring, and I know everybody who's here appreciates it. Just a reminder that on Monday, you will receive an email from GTF with a survey with links to recordings and additional important information. We would so appreciate you filling out the survey because it will help us in planning future ones. And we're also able to use that information to apply for grants for funding to provide these sorts of conferences free of charge. And you'll also get a link to the recordings from this morning's webinars and the doctor presentations that you're about to attend. Now, please listen carefully. This is very important for how you will get to the organ-specific doctor talk. So first, if you are a kidney patient, you don't need to do anything. Just stay put right where you are, and Dr. Graves will start her talk in a few minutes. If you are a heart, lung, or liver patient, in just a second, we'll put the link in the chat box. You'll copy that link and paste it into your browser so that you can go to the new session. It's a new Zoom session that you'll go to. And we have the meeting ID and passcode there. Once you're in that meeting room, you can select the organ breakout that you'll attend. And please just give it a couple of minutes. You know, everyone will need a chance to log in, and then you'll hear from the doctors. If you're having any trouble at all, please just send a message to us in the chat and tell us which organ group you want to be in, and we'll help you get there. If you do have any additional questions or want to connect directly with the GTF team, you can reach out directly using the confirmation contact information on the email you received from us, or you can reach out via Facebook or directly from our website. Thank you so much for being here today, and we really hope you enjoy the doctor talks. So is everybody seeing the link and able to use it? Please feel free to send us a chat if you're having any trouble. All right, we're gonna stay here. We're gonna give people just a few minutes to exit this session and go to their breakout rooms, and then we will hear from Dr. Graves. Anybody who's here who doesn't want to hear the kidney talk, you can use the link to go to the breakout session or chat if you are having a tough time with it. So we will give one more minute, and then I'll introduce Dr. Graves. All right, I think we're ready. So I would like to introduce you guys to Dr. Graves. Dr. Sharon Graves is an assistant professor of medicine in the Division of Transplantation at Emory University School of Medicine. She earned her medical degree from the University of Alabama, Birmingham in 1998 and completed her residency and fellowship at Emory University School of Medicine. Dr. Graves is a member of the American Society of Nephrology and American Society of Transplantation. And just a reminder, you guys, please feel free to send any questions you have through the Q&A, and we will make sure to try to answer those for you.
Hi, Rebecca.
Good morning. Thank you so much for being here, Dr. Graves.
Good morning, everyone. It's nice to be invited to speak, and I'm really excited. So let's see here. So today I'm going to talk with you about kidney transplantation. As Rebecca mentioned, I'm a transplant nephrologist at Emory University. I've been on the faculty there since 2001, and I'm really, really excited today to talk with you more about kidney transplantation, about our wait list, about the different transplant options, and about the benefit of kidney transplant. As Rebecca mentioned, if you have any questions, please feel free to put them in the chat, and Rebecca's going to stop me periodically and let me know what questions you might have. So first of all, why should we encourage patients to receive a kidney transplant? Well, first of all, there are growing rates of patients in the United States who are developing kidney failure. These kidney failure patients have different treatment options, including dialysis, and there are a couple of different types of dialysis, or transplantation, or supportive care. The outcomes really for patients with kidney failure are best with transplantation, and I'm going to show you some information about that in upcoming slides. Despite the technical and medical advances in dialysis, the outcomes of patients on dialysis remain poor. The yearly mortality is around 20%. So if you were to go to an average dialysis unit in the United States and look around, on average, 1 in 5 patients in that dialysis unit would pass away within the next year. The 5-year survival rate of dialysis patients is only about 35%. So 35% of people living after 5 years of dialysis. And this survival is worse than the survival of most patients that have cancer. Furthermore, mortality on dialysis is even higher in elderly patients. And most of this mortality is driven by cardiovascular disease. So patients having heart rhythm abnormalities or heart attacks. This is sort of a busy slide, but to summarize, we're looking at a comparison of mortality in all patients on dialysis versus patients on dialysis who are on the kidney transplant waiting list versus patients who have received a kidney transplant. And in general, this slide will show, yes?
I'm so sorry to interrupt. I'm not seeing your slides.
Oh, I'm sorry. Let me just see. Hold on. Give me just 1 second.
Absolutely.
Hopefully this will be better.
Yes, there we go.
So sorry.
No, no problem.
All right. So, and you can see this whole slide here?
Yes. Yep,
Okay.
looks great.
So this slide shows that the mortality in patients with kidney transplant is significantly less than the mortality of patients who are on dialysis. So looking here to the table on the left, this is the annual death rate and total numbers of deaths in patients either on dialysis on the kidney transplant waiting list, or patients who had a kidney transplant. And these were patients who were examined between the years of 1991 and 1997. And the main point of this table is really summarized in this line here. And this is looking at all patient mortality of patients on dialysis. And this was 228,000 patients on dialysis in the United States during 1991 to 1997. And the mortality was 16 deaths per 100 patient years. Now, comparatively, the mortality of patients who are on dialysis but waiting for kidney transplant, and we assume this is a healthier list of patients that are able to qualify for kidney transplant. So the two populations of patients are a little bit different. So patients who were healthy enough to be on the waiting list for kidney transplant, their mortality was around 6 patient deaths per 100 patient years. So that's almost 3-fold less. And the rate of death over 1991 to 1997 for patients who had a kidney transplant, this is around 23,000, was around 3.8 deaths per 100 patient years. So not maybe 1.5 times less rate of death compared to patients who were on the kidney waiting list. So this slide pretty well here shows us, this table, that survival of patients with end-stage renal disease with kidney transplant is the best with the lowest mortality. Now, we do have to talk about the fact that there is some mortality associated with undergoing transplant and having a transplant surgery, and that's sort of this half of the slide. This is the slide looking at the survival of patients as they receive a kidney transplant moving forward. And on this axis, we have the relative risk of death. So this 1.0 is basically the same risk of death if you were on dialysis versus having a kidney transplant. And so during the first 2 weeks of kidney transplant surgery, there's a 2.8 increase in the risk for death. And this is related to the complications of having a moderate risk surgery. But once when we reach 106 days, the risk of death for transplant patients is equal to the risk of death for a patient who had remained on dialysis for 106 days. And for every day beyond 106 days, the mortality for transplant patients is actually less than the mortality for remaining on chronic hemodialysis. And so we see there's a good long-term benefit to kidney transplant that begins once when patients have survived approximately 3 months post-transplant. Now, a 2.8 increase in the risk for death at the time of transplant might seem like a concerning number. Remember, this is a relative risk. So what is the absolute risk of death if we're talking about numbers? And I think that's important to talk about. And so the 1 year survival, this is how many patients are living with the kidney transplant, a deceased donor transplant, is around 97%. And the 1 year survival of patients receiving a living donor kidney transplant is around 98.5%. So you can see the amount of deaths with kidney transplant in the first year is still a very, very low number, although the risk of death during that first 30 days after transplant is increased. So this is looking at our kidney transplant waitlist for adults, and these are the trends in kidney transplant waitlisting for between 2004 and 2014. So this graph here is showing the number of patients that are newly listed for kidney transplant each year between 2004 and 2014. And this axis here is the number of patients in thousands. So this is 20,000 patients, 40,000 patients, and so on and so forth. And so if you look at this first graph, and again, this is the number of patients who are being added to our wait list each year during this time frame. If you look at the number of all patient types that are listed, we can see that over time, that number over this 10-year period has been increasing, with approximately 20,000 patients listed to our wait list in 2004, and approximately 30,000 patients listed in our wait list in 2014. Now, if you look at the types of patients who are being added to our wait list, there are two types. So one is active listing. So active listing are patients that are listed as status 1 active that are felt to be ready for transplant. They have completed their workup. They're felt to be at an acceptable level of health with good social support, and they are ready for transplant. And you can see this number of patients listed as active each year has remained relatively stable over the past 10 years, with around 20,000 patients being ready for transplant and listed. If you look at the number of patients that are listed as inactive over this time, you can see this number has been increasing. And so most of the growth or the increase in the number of patients on our list is occurring by growth on the number of patients who are listed as inactive on our wait list. And the reasons for this are that in our prior allocation system at this time, this is 2014 and prior, the primary driver of receiving a kidney transplant was time people accrued on the waiting list. And that time began when you were listed, whether you were listed as active or inactive. And so a patient who might have some relative reason they're not ready for transplant right now that we think would improve in a year, we perhaps would list that patient as inactive so they could obtain that year of waiting time. And this is one of the faults of our prior listing system, was that we were forced to list people for transplant who might not quite be ready because they needed to be able to accrue the waiting time. Now, if you shift over to the right side of the slide, this is looking at the number of patients who are on the total waiting list at the end of each year. So this is, again, people added that are new. This is our total number of waiting lists, people that are waiting in that year, as well as people that have been added during that year. And this is the years 2004 through 2014. And what you can see is over this 10-year period, initially in 2004, there were about 58,000 patients on our kidney transplant waiting list. And by the time we reached 2014, that number had increased to 100,000. So quite a bit of growth in our transplant waiting list over a 10-year period. And during this time, of course, there was an increase in the number of patients that were listed as active, but there was also a greater increase in the number of people who were inactive, such that by 2014, almost 1/3 of the patients on our waiting list were listed as inactive, not ready for transplant. 73% of patients who were listed as inactive on day 7 were still trying to complete testing to be listed as active. And interestingly, of the patients who were active at the end of 2014, almost 40% that were made inactive because of declining health. And so again, one of the problems in our waitlisting system has been that patients are waiting so long for transplant, and some are not healthy enough to remain active or may even be removed from the waiting list during their waiting time. And this is in a system that's based primarily on allocating organs based on waiting time, independent of people's health. And so we realized for many years that there were problems with our allocation and that we needed to make some changes in the allocation system. So in December 2014, our kidney allocation system changed. So going back historically, when we first designed the kidney allocation system, the primary driver of receiving a kidney transplant and organ allocation was a degree of biological matching between the kidney donor and the recipient. And so in our initial system, patients received points to put them higher on the list if they matched at certain proteins, HLA-A, and B, and DR. And so the kidney matches were made based on patients having a closer biological match with their donor and likely a better outcome. Over time, with improvements in immunosuppression medications, we downgraded the points for HLA matching, and so the points for A matching and B locus matching were removed, and basically the allocation then became driven by the amount of time that patients were on the waiting list rather than by their matching. So in the end, over-reliance on waiting time has led to a system that doesn't really accomplish any goal other than transplanting candidates who are waiting the longest. So this system that we were living in does not really recognize that not all patients have the same ability to wait and survive this long wait. And so these limitations led to formation of a committee that attempted to redesign the kidney allocation system to achieve certain goals. And those goals included having a better balance of equity, of access to organs for everyone, as well as utility. So considering what type of kidney we're providing to patients based on some patient characteristics and kidney donor characteristics. So one of these goals, the first proposed change, was in longevity matching. So unlike the allocations for livers and for hearts, and so in liver and heart allocation, the allocation of organs in heart is based on severity of illness, and so your status of listing can change based on how ill you are or if you're hospitalized. And with the liver system, it's based on the MELD scoring, and so MELD scoring is a calculation that takes into account several different patient factors that predict mortality. The kidney system did not have any scoring for allocation in the old waitlist system. And so the idea with this first proposed change was to try to initiate some type of scoring system to help better match kidneys with patients. And so this longevity system is to match kidneys with the most that are the most long lived with patients who are most likely to survive the longest. And so in order to do longevity matching, you need to understand a little bit more about your patient who's being transplanted, as well as the type of kidneys that are being offered. So the first part of this longevity matching is the estimated post-transplant survival score. And this is based on several different factors. And this is going to try to predict sort of the longevity or health of our potential kidney recipient who's waiting for a kidney. And this score is more predictive than age alone. And so in this system, the top 20% of candidates that are listed who have the best EPTS scores are going to receive kidneys with the best KDPI scores. And we're going to talk about EPTS scores and KDPI scores and what they are in the next few slides. So the EPTS score is the estimated post-transplant survival score. And this is a number that is calculated and it's assigned to all adult candidates who are on the kidney waiting list. And it's based on 4 factors, including candidate time on dialysis, whether the candidate has diabetes, whether the candidate has received prior organ transplant, and the candidate age. And these factors are put into a formula, and this formula generates an EPTS score. The candidate's EPTS score can range anywhere from 0% to 100%. So what does the score mean? Candidates with EPTS scores of 20% or less, so these are considered very good scores, to have a lower number is good, are going to receive offers for kidneys from donors with KDPI scores of 20% or less. And so KDPI scores of 20% or less are considered to be very high quality kidneys. And they're going to receive these candidates that are generally the healthiest on our list are going to receive priority to these healthier organs. I shouldn't say healthier, but these organs that are predicted to survive a long period of time. And they're going to receive priority to these organs before candidates at the local, regional, and national levels of distribution. So let's talk about we talked about how we sort of assign a EPTS score to a potential kidney recipient. How do we classify our kidneys? And so, as I mentioned, every kidney has a score. So every kidney offered for transplant has a kidney donor profile index score. That's the KDPI score. And again, like the EPTS, this percentage ranges from 0 to 100%. This score is attempting to predict how long a kidney will function compared to other kidneys that are available. And again, this score, in this scoring system, a lower number means that this kidney is predicted to survive for longer. So a KDPI score of 20% means that we expect that this kidney is likely to function longer than 80% of other available kidneys. And likewise, a KDPI score that is higher means that this kidney is likely to function longer than a lower percentage of kidneys. And so we're kind of assigning a gradation of expected kidney survival based upon this KDPI score to try to help better match kidneys to patients that are likely to live longer. And so again, if we assign a kidney that's predicted to last longer to a kidney that we think has a very good, to a patient who we think has a very long lifespan, then that patient is less likely to need transplantation of a second or a third kidney. And so in this way, we can help decrease the number of patients who are relisted for second and third kidney transplants, or at least delay that listing for a second or third kidney transplant. So the kidney donor profile index is again calculated with the formula. And this score is going to estimate how long the kidney is likely to function compared to other kidneys. The donor variables that we assess in this calculation include the donor age, height, weight, and ethnicity, whether the donor has a history of hypertension or diabetes, the cause of death of the donor, the serum creatinine, which is the kidney number for the donor, whether the donor has hepatitis C, and whether the kidney will be donated after cardiac death. And so if you look at the estimated graft survival by the kidney donor profile index here, and this is the kidney donor profile index. We talked about 20% is a very good kidney donor profile index with a kidney that's predicted to have a long survival. And as we go out on this frame, these kidneys are going to be surviving for lesser periods of time. And if you look at graft survival rate, you can see that with a KDPI of 20%, this is 1 year survival on this curve. And this is for the different KDPIs. This is 2 year survival. You can see that with a KDPI of 20% or less, patients are having very good 1 and 2 year graft survival, with over 92% of patients, or so 92% of kidneys surviving at 1 year post-transplant, and 88% surviving at 2 years post-transplant. And of course, as the KDPI goes up, again, we understand these kidneys are not going to function as well, particularly long-term. We can see there is a decline in the graft survival at 1 year post-transplant, but still pretty good, even with a high KDPI. But as we go out to 2 or more years, the graft survival of these kidneys begins to decline a little bit faster. So another concern within our prior waitlisting system was the fact that sensitized candidates are known to wait substantially longer to receive a kidney transplant. So what exactly does sensitized mean? And so one of the parts of kidney transplant, one of the blood tests that we measure is looking for antibody in the blood. It's called HLA antibody. And this is looking for antibody in the blood of the patient who needs a kidney transplant, and it's to see how many antibodies this patient has. And the more antibodies to human tissue that a patient has, the harder they are to match. And so patients that are very highly sensitized will be harder to match. And so there's a scoring system for this. It's called the calculated, which is the C, PRA, which is panel reactive antibody. And this is basically a percentage of antibodies that you have that will make it hard for you to match. And so if you have a CPRA of 98%, it means that a simple way of looking at it is it means that you're likely to not be a match for 98% of kidneys that are available because you have antibodies that would react with those kidneys. And so we've known for a long time that candidates that were very highly sensitized with CPRAs of 98% or greater are going to be very difficult to match. And these patients are going to wait many, many more years compared to a non-sensitized patient. And so we realized that we needed to do something with the allocation system, make some changes to help equalize the waiting times between patients that are unsensitized versus those that are highly sensitized. In our former waitlisting system, 2014 and before, that we only prioritized sensitized candidates at the local level. So if you were highly sensitized, then you got first offer to any kidneys in the local level, which might be, for instance, in the state of Georgia, but you really didn't get offers for kidneys outside of Georgia with any priority. You may have been way down the list, but you wouldn't get priority to be listed to receive those kidneys. So the new policy actually changes the priority. So patients that have a CPRA of 100% get access to all kidneys, even at a national level. And so that means that we may be transporting or flying kidneys over longer distances to transplant patients that are highly sensitized. And likewise, patients with a PRA of 99% will get access to regional kidneys. So this might be, and I'll show you the regional map in a few slides coming forward, but the regional map usually includes several states. So you would have access to kidneys locally in the state of Georgia and within a few other states. And then CPRAs of 98%, which, although that's high, these patients are not really felt to be the hardest to transplant. These patients will continue to receive local priority. In addition to receiving priority, the highly sensitized patients also get more points on the waiting list on a sliding scale. So patients earn points for time that they are waiting on the waiting list. They earn points for having an HLA-DR match, and they're now going to get extra points to if they have high PRAs, and these points are all combined and they help to direct your place on the list. And so if you went on to dialysis at the same time as a friend and you both get on the waiting list, for instance, in 2020, but you have a high PRA, then you would be placed ahead of your friend on the waiting list because it's going to be harder to transplant you, and you're going to be placed ahead on the list because you get more points for having a high PRA. And again, it doesn't give you an advantage necessarily to have more points. It tries to give you a fair playing field. It tries to the system tries to acknowledge that you are going to be harder to transplant. You will have to receive more kidney offers to find a suitable kidney, whereas your friend who has no antibodies may be compatible with the first kidney offer they get within their blood group, whereas it may take you 100 offers to find a compatible kidney. So that is how we've changed our allocation system for the better to help equalize the playing field for patients who have high levels of HLA antibodies. So the new allocation system began in December of 2014. What are the overall effects of our new system? So what we find is that this new system has resulted in an increased number of kidney transplants across the United States. It's resulted in increased transplants for those who've been waiting a long time on dialysis. The number of transplants for African Americans and Hispanic patients has increased. There have been increased transplants for highly sensitized patients. There is a slightly higher discard rate, and there's more shipping of kidneys around the country. So shipping means when kidneys are usually, flown or driven, and this is because part of this reason again is because the highly sensitized patients have access to kidneys across the nation, and those kidneys are going to have to be shipped. And so this has resulted in more shipping of kidneys around the country, and also an increase in the rate of delayed graft function. So delayed graft function is what happens when a patient's kidney does not work in the first few weeks after transplant, and it's defined as needing to receive dialysis in the first week after transplant. The delayed graft function rates are typically around 25 or 30%, and delayed graft function rates can be increased in patients that have been on dialysis for long periods of time. And since we're transplanting patients who've been waiting longer on dialysis for a longer period of time, that has driven up the rate of delayed graft function, as well as the fact that we're shipping kidneys. So when you ship kidneys, you increase the time, what we call the cold ischemic time. So it's the time that the kidney is on ice out of the body. And the longer that time is, the more time it takes for the kidney to wake up after transplant. And that results in more kidneys needing more patients that get kidneys that are sort of sleepy with delayed graft function. More of these patients need dialysis until their kidney wakes up. So I was just looking on UNOS last night, or in the early hours of this morning, and currently almost 107,000 patients are in need of a life-saving organ transplant across the United States. And this is all organs, including heart, lung, liver, kidney, pancreas, and small bowel. And of those, about 64,000 people are active waiting list candidates. So you can see quite a few patients are not active on this waiting list. So let's talk a little bit more about deceased kidney donation. So deceased donor kidney transplants currently account for about 65 to 85% of all kidney transplants each year. For patients who are not lucky enough to identify a living kidney donor, they must wait on our deceased donor, also known as cadaveric donor, kidney transplant waiting list for a potential donor. And that's the waiting list that we were talking about in our previous slides. There are more than 90,000 patients on the waiting list in the USA currently. This is waiting list for kidney transplant. About 37,000 patients are added to our kidney transplant wait list each year, but only 17,000 kidney transplants occur each year. The waiting time for potential kidney varies among different regions and is also dependent on the blood type and the degree of antibody sensitization of the patient. So if you look at kidney allocation in the United States based on UNOS regions, you can see that there are 11 UNOS regions across the United States. And the Georgia region is region 3, and this includes several different states. And as I mentioned, when I talked about allocation of organs to highly sensitized patients, that local allocation of an organ would be in Georgia, but regional allocation would include all of these states. So patients that are highly sensitized would either have access to regional allocation, or again, if they have really high PRAs, to nationwide allocation. The waiting time, again, depends on the region. That's a matter of supply and demand of the organ within the region. And the main factors that affect waiting time, as we talked about, are time that you've been on the waiting list and your panel reactive antibody, how sensitized you are. So let's look at waiting time by blood type in our region versus US. And so what you can see here, this is region 3, which includes all those states that I showed, including Georgia. And the waiting time for O blood type is approximately 1,600 days. And so that's about 4 years post-transplant, or sorry, 4 years waiting time for a transplant. And that's not very different from the US data. The US data shows slightly higher rates, about maybe 9 months more waiting time to receive an O blood type kidney. For B blood type kidney, you can see that the waiting time is very similar nationwide compared to Georgia. And then for A blood type and for AB blood type, our waiting times are a little bit shorter. And so in general, in the Southeast in region 3, our waiting times for most kidney blood types are lower than the national average. So how about living kidney donation? Why should we encourage people to find and receive a living donor kidney transplant? Well, first, living donor kidney transplants last longer. So if you look here, this is the years of survival of the average kidney, and the years of survival of the average deceased donor kidney is around 14.7. So about 14, 15 years is the average life of a deceased donor kidney. And for a living donor kidney, it's somewhere up in the low to mid 20-year range. And so the survival of a living donor kidney is better. And so one of the reasons for this is probably that living kidney donors are very healthy. So living kidney donors generally have to have good kidney function, no or mild high blood pressure, no diabetes, and we're able to study living kidney donors to make sure they're very healthy and to ensure that it's safe for them to give a kidney and that their kidney function is good enough that they could live their remaining life on one kidney. And so living donor kidneys are of a higher quality in general than the deceased donor kidneys that we receive. So kidneys transplanted from living donors are superior and last nearly twice as long as kidneys transplanted from deceased donors. How about receiving a kidney transplant before a person starts dialysis versus after they start dialysis? And so what we do know is that patients that receive a kidney transplant within a year or before starting dialysis have better survival of their kidney transplant organ. So receiving a kidney transplant before you start dialysis is referred to as preemptive. So a preemptive transplant is transplanting someone who is not on dialysis. And preemptive transplant patients have better graft survival. So this is 75% graft survival, and this is at 10 years post-transplant compared to the survival of patients who have been on dialysis, so a lower survival. So we want to encourage patients to receive and find a living donor kidney transplant because it results in longer lasting kidney function and again, better survival of the kidney organ if you get a kidney before you start dialysis. The other thing that I not mentioned.
Oh, I'm sorry to interrupt. We have had a question come up about this slide and also one about the last slide. Is now a good time to ask?
Sure,
okay.
The last slide being this one?
No, actually it was the one with the map of the, that one. So somebody said, have the regions changed? And can one register only in one hospital per region for a kidney transplant?
So that's a fantastic question. So I don't think the regions have really changed in a while. And patients can list in multiple transplant centers within a region, and then they also list outside their region. One of the issues with listing outside the region is just sort of financial hardship. So if you're listing for a transplant in another region, then there's usually quite some distance to get to that transplant center. And transplant centers often want you to stay locally for the first month. It varies from center to center, but they want you to stay locally because you're going to have follow-up visits post-operatively almost twice a week in most programs for the first month or two. And so there are some financial hardships that people would experience if they are listing in a center that, say, is a 6-hour drive away, and also if they don't have family in that state, that they would have to stay in a hotel. And so one of the challenges with patients listing in different regions is going to be, travel time and distance and lodging and the cost of all of those expenses. So that's the first issue with listing in a different region. But you are allowed to do that, and there are some few people who live in the Northeast who list in the Southeast because our waiting times are a little shorter, but they have to have the ability to fly here when they need to get a transplant, and often those patients may have family that are living locally that they can stay with, and so that makes it easier. With regards to listing at one or more regions in the state, it used to not be of benefit for a person to list at more than one institution in their state because the centers in the state share the same organs. So if you were on a list, say at Emory, and then you listed at a different center, on the state list, you're still going to have the same rank. Like if you're the 5th person for an O blood type kidney, you'd be 5th, whether you're on the state list, wherever you're listed. And so there was no advantage to listing in multiple programs. However, there was a recent change in allocation where kidneys are now allocated at nautical miles around a transplant center. And I don't think I can explain that well, but the transplant center capture area that's considered, I guess, local, is 250 nautical miles around the transplant center. And so now, there's a transplant center in the state that's up in the north and one is down in the south, then this center in the south would have access to other organs that are further south that this center wouldn't have access to. And so now there is some rationale for patients considering listing at multiple transplant centers within the state, as long as they're significantly separated by distance. It wouldn't make sense to list in transplant centers that are only, for instance, 30 miles apart, but in transplant centers that are, several hours driving distance apart, then the allocation of organs, you may receive organs from the north in a center in the north that you wouldn't have access to if you were just listed in this program. So some patients are listing in certain states that have multiple transplant programs. Not all states do, but in certain states that have multiple programs, some patients are listing in geographically diverse programs within their state.
Okay,
And
thank you.
Sure. And then there was a question about this slide.
Yes, so one of the questions was about how, I'll just read it to you. Are patients that are considered brain dead in a hospital with their bodies/organs being kept alive considered deceased donors or living donors?
So that's a great question. So patients who are brain dead being kept alive by artificial means are considered to be deceased donors. And so yes, so those are considered to be deceased donors. Living donors are going to simply be patients who are living and healthy and walking, but among deceased donors, we have the standard criteria donor, which is usually considered a brain death donor. And then you have donors who are donation after cardiac death. And so those are donors that we withdraw life support and we wait to make sure that the heart does not function, and you take patient off life support. And if the heart doesn't function, you have to wait a certain period of time, and you declare death, and the patient's organs are then procured. So there's two types of deceased donors. There's the brain death donors, and then there's the donation after cardiac death. The donation after cardiac death donors can be good kidneys, but there's a higher rate of delayed kidney function with those kidneys because there is a time when you're waiting for the heart to stop, and you're giving a certain number of minutes to make sure that the heart has stopped and the patient has stopped breathing, that during that time the organ may not be getting any blood supply. And so these kidneys will again have a higher risk of being sleepy after transplant, and the patients will likely need dialysis for some time after transplant. But the outcomes long term of the DCD, donation after cardiac death kidneys, are very good.
Got it. There was also a question about the sleepy kidneys. So if somebody gets a kidney transplant and the kidney does function and wake up immediately, is that an indicator that it is, going to have good longevity? Or on the other hand, does a sleepy kidney mean that it may not have good longevity?
So sleepy kidneys can do just as well as kidneys that are not sleepy. And we spend a lot of time trying to reassure patients of that. Again, the fact that a kidney is sleepy doesn't necessarily indicate that the kidney is not robust or will not function well long term. Again, it's just often a consequence of events that happen to the kidney as it's being procured. So for instance, again, if a patient passes away and the kidney's procured and placed on ice, and then it has to be flown somewhere and then transported, and that kidney, might be on ice for up to, 18 hours by the time you get the kidney to a center, you bring the patient in, you do your preoperative testing and get to the operating room, then that kidney has been on ice for longer. And we know that the time that the kidney is on ice is correlated with the chance that the kidney will be sleepy. And the longer the kidney is on cold storage and ice, the greater the chance of the kidney being sleepy. So, so the reason why you don't see much delayed graft function or sleepy kidney in living donors is because generally living donor kidneys are, transplanted shortly after they're procured. And so, often if it's a relative or friend giving a kidney to the recipient and the transplant surgeries are going on in the same hospital, and literally the kidney is taken out of one body, taken over to a different operating room just down the hallway, and the kidney is put into the body. And so those kidneys have low rates of delayed graft function, but it doesn't necessarily mean that makes them better. So the answer is no, that having a sleepy kidney does not mean that this kidney is likely to function less well in the long term.
Okay, thank you so much. Those are all the questions that go with what you've been talking about now. Thank you.
Okay, thanks. So if you look at living donor kidney survival versus deceased donor kidney survival, this is just another slide to illustrate the improved survival that we see with patients who receive a living donor kidney. You can see the 1-year survival rate of deceased donor kidneys and living donor kidneys is very good, 96, 97%, so almost the same. But when you start to get out a little bit further, at 5 years post-transplant and 10 years post-transplant, you can see that the survival of the living donor kidney is superior at 5 years post-transplant and 10 years post-transplant compared to the deceased donor. And again, that's just, I think that living donor kidneys and deceased donor kidneys comparatively are like apples and oranges, because living donor kidneys, again, these are kidneys coming from living donors that are very healthy, healthier than the average person in the population, that are well studied. And we screen the donors for high blood pressure and for diabetes and high cholesterol. These are very, very healthy people who are giving a very, very healthy kidney. I mentioned about the deceased donors that we have that KDPI score, the Kidney Donor Profile Index, and you saw on that deceased donors can have different conditions like high blood pressure, history of diabetes, and we know that the deceased donor kidneys are a spectrum. So some of the deceased donor kidneys, perhaps someone who unfortunately, a young person who dies in a car accident, are going to be very good quality, and those kidneys are going to be similar in quality to a living donor if it's a young person who's passed away. But that's not most of our deceased donors. Most of our deceased donors are not young people, and many of our deceased donors have high blood pressure and or diabetes, or they died of a stroke, and so they have kidney function that's not entirely normal. But again, an average deceased donor kidney life of 15 years is 15 great years for a person, right? So that's not to say that deceased kidney donors aren't appreciated or they, aren't good kidneys. It's just there's no way that you can generally compare the survival of a deceased donor kidney with a living donor kidney, because living donors are so healthy. So talking about living kidney donation and direct donation. So direct donation means being able to give a kidney directly to the person that you're hoping to donate to. So this could be a friend donating to a friend, or a family member donating to another family member. And there are several hurdles that people have to overcome to directly donate to their kidney donor. So first, to be a kidney donor, you have to be healthy, very healthy. Second, to donate to your intended recipient, you have to be blood type compatible with them. And third, you have to pass cross-match testing. So this has to do with the HLA antibodies and sensitization that we mentioned. So you have to be blood type compatible, and we also have to make sure that your recipient doesn't have any antibodies which would attack your kidney if you're the donor. So problem, 1 in 3 donors cannot donate to their selected recipient due to blood type incompatibility or a positive cross-match. So in the past, this was a tragic situation. A patient would have someone who really wanted to donate, who appeared to be very healthy, but they weren't a match. And we would say, we're sorry, your donor's not a match with you. You're just going to have to continue waiting on the waiting list. But many years ago, we found a solution. And the solution is paired donor exchange. So the potential solution is to identify another donor and recipient pair who are also incompatible, and to try to exchange donors if the donors are immunologically cross-match negative with the other potential recipient. And so to show this in a graphic form, this is a simple example of a two-way exchange between 2 pairs of people. So for instance, donor 1 would like to donate to recipient number 1. Say it's a parent donating to a child, but they're not compatible. And say this is a sister, donor 2, who wants to donate to her sister, but they're not compatible. But what if this sister is compatible with this child? And what if this parent is compatible with this sister? Then we can do an exchange. And so these donors cannot donate directly to their recipient, but through paired exchange, they can donate to someone else. And that allows the person they want to give a kidney to receive a kidney from someone else. So this is paired donor exchange. And so it's a way to facilitate patients receiving a living donor kidney, even if they can't receive a living donor kidney from the donor that wants to give them a kidney. Now, these exchanges can become even more complicated. So they can involve anywhere from sometimes 3 pairs of people to even 6 or 7 or 8 pairs of people. And so in this slide, you can see there are multiple donor recipient pairs that are not compatible with each other. But if donor A is able to give to recipient B, and donor B gives to recipient C, and donor C gives to recipient A, then everyone, like kind of like by a domino effect, everyone is able to receive a kidney. And this would involve 6 different people. So what are some of the benefits of paired donor exchange? Well, first of all, we obviously mentioned that this is going to enable certain patients to receive a living donor kidney transplant who in the past, when their living donor was not a match for them, were turned away. Second of all, this system allows us to improve HLA matching. And so we talked about the fact that over time, the ability to HLA match has become less. We've taken away points, and people were getting transplanted primarily based on waiting time. But in the paired exchange system, you have a database of donors, and we know their proteins on their cells. And so we can try to match the donor proteins with the recipient more closely. And you can see that when you match antigens, so when the donor kidney tissue has certain antigens, proteins on it, and if you match those proteins with some of the proteins found in the recipient, then the chance for rejection is less and the survival of the kidney is better. So in other words, you're trying to find, again, more of a biological match. And you know, this is most evident with receiving kidneys from family members, that often these kidneys are a better match because genetically you've inherited some of these proteins from your parents and share some of these proteins with your siblings. And so you can see that as we match more proteins, as we match more proteins between the donor and the recipient, the kidney outcome improves, especially when you're looking at being able to match 6 very important proteins or 4 or 5 proteins. We can also try to perhaps age match the donor and recipient a little better. So perhaps you could arrange a pairing where a donor parent, instead of donating their kidney to a child, perhaps that donor parent donates their kidney to another older adult, and maybe that older adult had a sibling that wanted to give, that gives to that parent's child. And so we can try to perhaps age match the donor and recipients a little bit better through paired exchange. So what about altruistic donors? So we have different terminology for altruistic donors, but basically if you have a donor that wants to give a kidney but has no intended recipient, it's just someone that says, you know what, I was reading about the need for kidney transplants and I'm healthy and I want to help someone. That donor is called an altruistic donor or a non-directed donor or a Good Samaritan donor. And so all of those terms apply. It's someone who does not have a particular recipient in mind, but they want to give a kidney to someone who is in need. So when we get altruistic kidney donor candidates, we often will have the altruistic donor donate a kidney into the paired donor exchange system. And this will set off a domino effect that will allow many other potential patients to be transplanted. Also remembering that with paired donor exchange, a lot of these patients that have a donor that's not compatible may be highly sensitized. So a lot of the patients that are waiting for a kidney in the paired donor exchange system are highly sensitized and difficult to transplant. And so the paired exchange system offers those patients a large potential pool of donors that might be a match for them, even if the patient has a lot of antibodies that makes it hard for them to be matched. Well, how about donor risk, you might ask? What risk is a donor undertaking to give a kidney? It's a frightening thought for some patients, but or some people, some individuals, but maybe individuals also want to learn more about it and want to help someone. So complications include postoperative complications such as bleeding, wound infection, and fever. And generally, this complication rate is fairly low. The recovery time is pretty quick overall. So these kidneys are obtained laparoscopically. Laparoscopically is when you use the small incisions and the cameras, and the kidney, the abdomen is inflated with air to allow for visualization of organs, and the kidney is removed through must be removed through an incision, however. So the incision is a little bit bigger, but there's one incision and a couple of little holes where they insert the cameras. And so this laparoscopic technique is less invasive, and the donor usually is going home from the hospital in 1 to 2 days after surgery. Donors often return to work in 1 to 4 weeks. And this, of course, depends on their occupation. So donors that are in a job that requires a lot of manual labor or lifting would take longer for us to medically approve them to return to work. And then we might approve them to return to work, but have lifting weight restrictions for them where we say you can't lift more than 10 pounds for the next 6 to 10 weeks. Long-term outcomes of kidney donors. So kidney donation does not appear to impact life expectancy. So we believe that kidney donors living with one kidney have the same life expectancy as other patients in the general population. Kidney donation does increase the risk for development of kidney failure over time. And so we look at the lifetime ESRD risk, and let's compare. So the lifetime risk of developing end-stage renal disease in the general population. So you take everyone in the United States and you look at the number of patients who develop kidney failure, it's about 1 in 30. This is every person in the US. If you look at a kidney donor's lifetime risk of developing kidney failure, it's about 1 in 10. And so you might think, well, that's better. Well, it is better because remember, kidney donors are among the healthier patients of the population. So if you look at patients who were evaluated to donate a kidney, but changed their mind or were excluded for some reason or other, so a pretty healthy population of patients who are as healthy as kidney donors, the risk of kidney failure is 1 in 700. So there is an increase in the relative risk of kidney failure, but it's still a very small number. The reason that kidney donors have a lower risk of end-stage renal disease, again, compared to the general population, is they're a healthier group of patients in the general population. So a lifetime risk of kidney failure, that's what, 1 in 110? That's about 1% or a little bit less in a lifetime. So just a brief slide about transplant immunosuppression medications. Our patients that receive kidney transplants have to be on immunosuppression medications, or we also call them anti-rejection drugs, to help prevent kidney rejection. Our program uses a triple agent regimen, typically for long-term maintenance. The primary medication is usually cyclosporin, tacrolimus, sirolimus, everolimus, or belatacept. This is combined with the second agent of immunosuppression that has different interactions on T cells and cell cycling, and most patients are on prednisone. And so patients are on typically 3 drugs for preventing rejection long-term. One of the drugs that I mentioned here on this slide, belatacept, was a drug that was developed at Emory, and it's the first drug in this particular class. And this class is called a co-stimulation blocker. And this class of drug is interesting because it's one of the first classes of drugs that primarily acts on the antigen presenting cell in the body. So in general, most of our medications are acting on our immune cells, so our lymphocytes. And the lymphocytes are the ones that instigate rejection and cause inflammation in the kidney and cause rejection in the kidney. But how that rejection typically develops is that an antigen presenting cell sort of notifies or activates the lymphocyte. And so the belatacept acts directly on the antigen presenting cell to decrease its ability to present antigen to the lymphocyte, so the lymphocyte cannot be activated. And then when it's activated, the lymphocyte multiplies and it goes to the kidney graft and causes inflammation and destruction. So the Sentinel belatacept paper was the benefit study. This is a phase 3 trial with 7-year, well, they presented data at 3, 5, and 7 years post-transplant. And the last report of patient follow-up was at 7 years. And at 7 years after transplant, in patients that were on the belatacept, patient and graft survival and the mean kidney function or glomerular filtration rate were significantly higher in patients receiving belatacept. So you can see here, months post-transplant, you can see the mean GFR. So GFR is like the percent kidney function, and you can see these are patients receiving cyclosporin, and these are patients receiving belatacept. You can see over time the patients receiving cyclosporin, this is around 60 months here, so 5 years. You can see at around 4 years there began to be a little bit of decline in the kidney function, slow over time. And in the belatacept group, you can see that kidney function was preserved or even possibly slightly better for several years after transplant. And so our hope is that with putting patients on belatacept as opposed to cyclosporin or tacrolimus, we hope that we can help patients have longer lasting allografts. And longer lasting allografts takes a longer time for kidney failure and a longer time to have to be put back onto the transplant waiting list. So hopefully this will help over time to shorten the number of patients that are on our waiting list from relisting. It's estimated that about 25% of patients on the waiting list today are waiting for a second or third kidney transplant, and there are a variety of reasons for that. But if part of it is related to drug toxicity to the kidney transplant from cyclosporin and tacrolimus, then possibly as we're using belatacept in more patients, perhaps we'll begin to see a long-term effect of that with less patients needing relisting.
And Dr. Graves, we have a question about belatacept. Does it have fewer side effects than Prograf?
So it does. So just a few things about belatacept. So first of all, in addition to being sort of having a novel new mechanism of action on the antigen presenting cell, it is I believe really the only drug routinely used that is infused. So all of our other medications for transplant are taken by mouth, but the belatacept has to be infused through the vein. So it's a drug that's taken once a month, whereas most of our transplant pills are taken once, twice, or 3 times a day. So it's an infusion protein, and proteins are large, and proteins cannot be absorbed through the stomach or the intestine. So large proteins such as belatacept have to be infused through the vein. So it's an infusion drug that's given through an IV, typically in an infusion center once a month. The side effect profile is better. So they saw, compared to cyclosporin patients, they saw less increase in blood pressure, less increase in lipids, and less increase in rates of diabetes. So so maybe people don't consider that to be the traditional side effect, but as medical doctors, we know that, increases in blood pressure, rates of diabetes, and lipids are not good for a patient and can increase the risk for development of cardiovascular disease and stroke. And so from a healthcare provider standpoint, those are very important benefits of the belatacept in terms of side effect profile to have lower rates of those conditions. I would say that a lot of patients on Prograf or tacrolimus may have problems with headaches or tremors, shakiness, and you don't see those side effects with belatacept. So I guess from that standpoint, yes, the side effect profile is different compared to Prograf.
Okay, thank you. Well, actually, we have had a couple of more questions come in about belatacept. Somebody says, can they change to belatacept after being on cyclosporin for 21 years?
So patients could change to belatacept after being on cyclosporin for all of those years, but we're not really sure after that length of time that it's particularly beneficial. If a patient has been on cyclosporin for so many years and their kidney is still, or their kidney or organ is still functioning, then they seem to have done very well on that regimen. Number one. Number two, when you change a person's immunosuppression medication regimen, there's always a risk that you could prompt a rejection. So you want to make sure that you're changing the medication regimen for a good reason, because we can't 100% guarantee that a patient wouldn't develop rejection when we change transplant medications. The third is that the benefit and preservation of kidney function in this one trial, really the benefit was only studied in patients who were newly transplanted. So, it may perhaps be that some of the benefits of being on this medication are negated after patients have been on Prograf or cyclosporin for a long period of time. It may be that at that point, you wouldn't get a lot of benefit by changing to a different drug, and you might increase your chance for having a kidney rejection.
Got it. Okay, thank you. That's really important information. If a patient is on belatacept, can they discontinue prednisone?
So that's a difficult question to answer. I would say there was an observational trial called the CTOT, and there were different arms of immune suppression regimens in this trial. And one particular arm was an arm of patients that received belatacept and a mycophenolate and did not receive prednisone, and the other arms of the trial included like belatacept, mycophenolate, prednisone. There was the tacrolimus or Prograf, mycophenolate, prednisone. And the trial enrollment in the arm that received belatacept and mycophenolate was discontinued because of a higher rate of rejection in the patients who did not receive prednisone. So there are some of us that believe that belatacept may be a drug that functions best in patients that are also on a regimen containing prednisone, but we don't really know. So I think the answer is that it's difficult to say if it's safe for a patient to be taken off of prednisone, honestly, in any regimen. There are some centers that do steroid-free regimens, and it seems like the best outcomes for steroid-free are to not do any steroid from the beginning. When you take a patient who's been on prednisone long-term and you wean them off of prednisone even slowly, there's probably, the publications give different numbers, but there's probably a 10 to 20% chance that patient could develop a rejection, in the next 6 months. And so we do try to minimize patients' prednisone doses, but we generally don't try to wean patients off of prednisone, especially the patients that are on belatacept, because of that trial data of higher rates of rejection in patients that just got the belatacept and mycophenolate.
Okay, thank you. Does Emory have a certain maintenance dose for prednisone?
So we have revised our immune suppression regimens over time. And, when I was way back when I was a fellow in 2001, of course, we didn't have belatacept, but our patients would all leave the hospital on prednisone 20 milligrams a day with their other transplant drugs. And they'd be on prednisone 20 milligrams a day for a month. Then they would slowly wean down to 10 milligrams a day, and then we would leave everyone on 10 milligrams a day. But over time, with more research and publications, we realized that patients could be on less steroids. And so over time, we first got rid of the 20, and then we got rid of the 10, and over the last 2 decades. And so currently our maintenance dose of prednisone for almost all of our patients is 5 milligrams a day. And that's in patients that are on belatacept, mycophenolate prednisone, or patients that are on tacrolimus, which is Prograf, or cyclosporin, mycophenolate, and prednisone. That almost all of those patients are on 5 milligrams a day of prednisone.
Okay, thank you.
So the last slide I wanted to show was just this one. I think the COVID years have been very hard on all of us. I don't think we ever thought COVID was going to last this long or have this type of impact on society in terms of people getting educated, the impact on social events like graduations and weddings, the impact on the healthcare system, or the impact on small businesses, and even people's employment. And there's been, I think, again, a really tough year in 2020 and 2021 with COVID, but I thought this was a really nice slide when I was looking online last night on UNOS. That was a bright point and a highlight here in the U.S. in the transplantation field. That is, the U.S. has the highest performing organ donation and transplant system in the world, and this occurred even in the midst of a global pandemic. So in 2020 was the most lives ever saved by deceased donors. And so you can see there's a 6% increase in deceased donors compared to 2019, more than 33,000 life-saving transplants from deceased donors, and it was the 10th record year in a row for increasing rates of deceased donation of organs. And so I wanted to sort of end our presentation on a bright spot in the middle of a global pandemic. That's something that we should be proud of and thankful for.
Definitely, that is a huge bright spot.
So also wanted to give a shout out to the GTF, the Georgia Transplant Foundation, for how much they enrich all of our lives, the lives of healthcare providers, the lives of transplant programs, the lives of all the patients that we serve, and all the wonderful things they do to support patients. We couldn't survive without the GTF. And I just wanted to say thank you for letting me be a part of this presentation today.
Oh, thank you. Thank you so much. And GTF, we are so happy to be able to offer programs like this and resources for patients. I know that our founder, Tommy Smith, would be so happy to see our organization, and we can't do it without the transplant centers and without physicians like you. So thank you. We do have a few other questions that have come in. One is, one of the presenters earlier talked about the Alisher testing that is one of the things that can be done for testing for potential rejection episodes. Somebody said, does Emory do Alisher testing?
So we are able to do Alisher testing. We do not really do a lot of Alisher testing right now because I don't think it's really been firmly established in terms of efficacy. So, I think, the role for potential Alisher testing, would be to try to determine who might be at risk for rejection. But I think it's also important for patients to understand that, at least in the current day and age, that the gold standard for diagnosing rejection and determining the treatment that's needed is really going to be a biopsy. And so Alisher, at least right now with the information it provides, would really not be able to alleviate or decrease the need for a kidney biopsy if we really suspect that someone has rejection. We're still going to need to do a biopsy of their organ, their kidney organ, because we have different severities of rejection, and the severity of rejection is going to dictate the type of treatment that we give. I can see, the potential in the future that, and we actually are going to be, I think in the future, going to be having a cohort of patients that will be receiving Alisher testing, that may be having some changes made to their basal immune suppression regimen, and we may be monitoring them with Alisher. And so that will be our first sort of toe dipping into the water with the routine use of Alisher, and we're going to see how that works out for a subset of our patients, sort of how predictive it is. And I think, when we get more, hopefully when we feel more confidence in the value of Alisher, then it may be moved more into the routine practice. But right now, it's something that we're going to begin using in a subset of patients to kind of see if we find that it's helpful for us and for our patients.
Okay, yeah, that makes complete sense. Thank you. Somebody asked, what is the current news in the area of a bionic kidney? Is it possible that that's something that's going to become available? From time to time, I read, I'm sure you all saw it was in the news about I think it was a transplant of a kidney onto was it the thigh or leg of a patient on life support. From time to time, we read these articles that are published about artificial kidneys that might, be bioprosthetic, so part, human tissue, part mechanical, or that might be xenotransplants, so, from other species like the fetal pigs that are raised in a lab. And, so far, none of these options have really been viable yet, but that's not to say that with more time that this won't be possible. It's just been a really a very difficult field. I think when you think about all the functions of a kidney, in the hormones that it releases to control anemia and to control our calcium, phosphorus balance, you consider the fact that the kidney is able to regulate electrolytes like potassium and magnesium and sodium and fluids. The kidney is really a very complicated organ. I think, designing something mechanical in a lab that can achieve these feats is a challenge. I think that, xenotransplantation, so trying to transplant organs from other animals into our bodies, is very captivating. But remember, we, aren't always genetically similar to these organisms. That's turned out to be one of the problems, is the genetic differences, sort of like being sensitized and having antibodies that make you not compatible with the person. There are different proteins that animals do not share with us that may be an issue. So the answer is, I hope that we have a bionic kidney. I hope we find a xenograft that works, and we, it may be around the corner, but we have been investigating these things for many years, and so far that hasn't really come to fruition. Right. All right. Well, yeah, we can keep that hope for the future. And then somebody put in here, Maureen says she was your patient in 2019 at age 75, and she is doing great.
Well, Maureen, shout out to you. That's fantastic. It's really good to have you here today.
And then we do have one final question. Do you have any thoughts on the possibility of having an opt-out system for donation on a driver's license instead of the current opt-in system?
I think that is a fantastic idea. And I think, in Europe, it is presumed consent. So in Europe, you do sort of have to opt out. And if not, then it's presumed consent that you're going to be a kidney donor. I haven't heard anything about changing the system in the US to opt out. It's been a long time since I've gotten a driver's license. I think when I renewed last time, I renewed for a 10-year license. And I seem to recall that perhaps I got a discount for being an organ donor, even though I would have signed up to be an organ donor anyway. But
I think they've taken that away.
Have they taken that away?
I think so, yeah.
Yeah, I can understand why they would. Again, I think there was a slight discount for being listed as an organ donor, but I think that does, that incentivization does go against our idea of that organ donation should be without coercion or financial compensation. I would love for consent to be presumed. I would love for people to have to opt out. I don't really know. I think that's something that we would have to discuss and advocate for with politicians in the state to get that kind of legislation in the state. And that's something that people should think about, even me now, think about approaching our senators and House representatives to talk about.
Absolutely. Yeah, it's definitely something that, it could be an effort to try to get that off the ground. Well, we've had many people say thank you. Scott says, thank you so much for presenting and answering my many questions. But that was such a great informational presentation that you gave. And we're so appreciative of your time and of talking to us today.
Well, I had a blast, and I thank you so much for letting me speak, and I'm so glad that people enjoyed it, and I'd be happy to come back and talk anytime again.
Oh, thank you so much. Well, I guess with that, we will close out our session. Just a reminder to you all that you will be getting an email on Monday with the recording, and then also with a survey link that we would really appreciate you filling out. And if you have any questions or want to connect with GTF, please feel free to reach out. And thank you, Dr. Graves. Thanks so much.
Sure.
So I hope
happy
you all have a
holidays,
fabulous
everyone.
day. Thank you to you too. Yes, happy holidays, and you all have a fabulous day.